one of the thing and key issue that was coming from plenary yesterday, or even from our keynote speakers, is HDC is a great platform that brings all of us together. A platform that we need to use to harness the power of data, a platform that we need to use as countries, as stakeholders, to build stronger data systems together in collaboration for informed decision-making and for better health outcomes. The other key discussion and recommendation that came from plenary is, okay, we are there. Okay, let me start now formally. Apologies for that. So as I said, we had keynote speeches from our speakers, and this is just a recap that really enshrines and gives us what HDC is. We have many other quotes, and we shall see them in the main report once we develop it, but we just highlighted these four. We had key message from Dr. Samira, and one of the key quote is, HDC is a large network advocating for better HIS, a powerhouse to ensure better data for better health outcomes. Yeah, of course, focusing on communities and the whole world. So a great platform that we can all use to focus on health of our communities, at our regions, at our countries, and also globally. Then we had reflections from Cabinet Secretary Representative, Dr. Bernard Langat, and he said that in Kenya, HDC has been central in promoting quality data for patient-centered care. And he gave an example of how Kenya has rolled out the electronic community health information system. Then we had a good quote on when the right data is in the right hand, at the right time, decisions can be informed better by Dr. Maria. And then some examples from many countries on how they learned from the marketplace, just to quote one from South Sudan, Matur, that the marketplace has been a great session for learning, experience sharing, and networking. And that is based on the objective one that we had. So this actually summarizes the discussions of the day. But since we had key recommendations, if we go to the next slide, please. So we had some discussions on country missions. How can we harness the power of bringing partners together to go to countries just to highlight priorities and any gaps and then agree on action plans? But we learned from Nepal, perhaps we need to sort some of the key issues, especially on development of reports. We need to be timely in terms of developing mission reports so that then stakeholders can then respond to the priorities identified during the reports. Then ensuring that we have actionable steps or clear roadmaps based on the findings of the reports and involvement of the regional offices. And we think we all have a role in that. Partners who are attending the missions, the countries, secretariat, and so forth. Then there was an aspect of how do we institutionalize HDC? And when we're going around the posters, there were examples like Cameroon anchoring it on the Public Health Institute, other countries having HDC in their existing frameworks, for example, their policies, strategies, annual plans, and so forth. And also the issue of translating the global agenda, the global HDC agenda to the regional and also to the country, but also importantly at the country level, ensuring that the HDC agenda and the issues of coordination and collaboration is also translated to the subnational level. Then we also discussed the issue of how the HDC value is evolving. We've been working towards, the issues of harmonization, coordination, of stakeholders, but we also learned from countries yesterday. Countries, for example, the issue of digitization and integration is one of the added value. And you need to evolve with that as data systems also evolve. Then one of the key recommendations was stakeholders engagement, and the key highlights was how best can we engage line ministries, other government agencies, for example, the Bureau of Statistics, Foreign Affairs, or any other government agency or ministry that deals with data. For example, CRBS data in some countries, Bureau of Statistics, and so forth, Foreign Affairs, and so forth. The other key stakeholder to engage, next slide, please, was the civil society. Basically, we agreed that we need to strengthen the engagement, especially at the country level, strengthening the engagement of the private sector. The other key recommendation was how best do we ensure that we have HDC materials that reach everyone. And the issue was, for example, the French-speaking countries may have limitations because we do not have materials in French. So we've agreed that we could then work on translating to French and any other language that is deemed necessary. CRBS across board was identified as one of the key challenge facing most countries. For example, the low birth registration, the causes of death data, and the need, therefore, to strengthen CRBS as a community of HDC. And later on, we shall be hearing from the working groups, and our colleague Doris will be presenting on CRBS and probably how best then we can work together to improve that. Then one of the other issue that was discussed was the issue of parallel data systems and the need, therefore, to integrate for more efficiencies, the issues of financial resources for HIS across board in all the posters. I think we did not have a lot of information on allocation to HIS. While we have the spending on health, generally, we do not know the spending on HIS. And therefore, they need to play the advocacy role for collation of data on financial resources that are going to health information system. And there was a country that proposed perhaps a 10%, this is just as an example, of health spending going to M&E. But later on, we shall hear on partners mapping, and I know we have discussed this with some of the countries as a way of advocating for resources to HIS and also mapping what is coming to HIS from across board, from partners and also governments. Next slide, please. This should be the last one. The other key issue was communication. How do we improve communication for HDC at the country level, at the regional level, and also at the global level? Then networking, we said that one of the objectives of the day was peer-to-peer learning, networking. How do we then maintain this? And would be interested maybe later on as we discuss is how do we move the good work that has happened in this room yesterday and today moving forward? How do we maintain the network of these practitioners, if I may say? Then coordination structure, some countries expressed the need to have some support in establishing the coordination structures, realizing that HDC does not duplicate structures, but encourage the use of existing structures at the country level. Then there was the aspect of capacity building, but we did discuss here as we are going around that there's need for specificity on what aspect of capacity. Is it analytics? Is it on data collection? And how best can we do it? And perhaps later on in the day, we can discuss how best to build capacity or even in subsequent forums. And then let's think of sustainability. I think that's what we discussed in a nutshell, and we are looking forward to engaging discussion today as well. Thank you very much.
Thank you. Thank you for taking us through the discussion for yesterday. I hope that puts us on the correct pace for another day, which we are starting now. So our first session for today is on technical assistance through working groups and regional platforms. And our facilitators for this session, Andrew from Uganda. I hope you are here. Andrew, not yet here. And Sri Lanka, Palita. You're here. Thank you. You will take us through. Maybe Andrew can join us in the process. Please step forward. Welcome.
Good morning. Good morning to all of you. This session, we are focusing on technical assistance through working groups and how the regional platforms can support countries involved in the HDC. So from 9:15 to 10:30, we have 1 hour and 15 minutes, and we have very packed presentations, 7 presentation and Q&A sessions. So first we start with the civil registration and vital statistics working groups. Bhaskar Mishra from the UNICEF will present.
Can you hear me? So good morning. Hope you rested well. So as you know, Civil Registration Vital Statistics Working Group is one of the 8 working groups of the Health Data Collaborative. And I'm privileged to co-chair this group with Doris Marfat, who's sitting there. And Deborah Jackson, I think she must be online. Can we go to the next slide, please? So the working group has 2 broad objectives. The first objective is that it serves as a conduit of information with and from other CRBS groups, such as Global CRBS Group, API CRBS of UNECA, the UN Legal Identity Agenda Task Force, UNSCAP, and other HDC partners. And we focus on enhanced sharing of information, identifying opportunities to support partners, and establishing better coordination and opportunities of collaboration among partners. The second objective is to coordinate and provide country support with best CRBS practices, such as simplification of CRBS processes, preferably through a one-step, one-visit. And the idea is that registration and certification should be done simultaneously. Engagement with health, education, social protection, and national ID systems. Ideally, we should have a health civil registration national ID pathway so that routine health sector data is used for notification, declaration, and registration. Such a pathway will also entail 2 advantages: collect information once and use multiple times and move information, not people. We also focus on universal birth and death registration, improvement in medical certification of causes of death, etc. And this we try to do by aligning global stakeholder support to countries and intensifying support for implementation of CRBS tools and resources that we have plenty in number. Can we go to the next slide, please? So in 2022, 2023, we focused on providing direct country support to Nepal, Kenya, Malawi, Pakistan, and Bangladesh. We had a joint mission to Nepal early this year and to Malawi last year. And we have been engaging intensively with Pakistan, Bangladesh, and Kenya. With Pakistan and Bangladesh, we have a mutually agreed roadmap. Things are a bit stuck with Kenya. We are in conversation with the CRS authorities, and hopefully we'll have a solution. We plan to have a shared understanding on the way forward. At the 2023 SDG Summit, we organized a side event on 15th September, and the theme was Unlocking SDG 16.9, Leaving No One Behind. We invited 6 countries, 3 from Africa, 3 from South Asia, and the countries were India, Pakistan, Bangladesh, Nigeria, DRC, and Ethiopia. These 6 countries together account for half of unregistered children globally, and their individual progress is critical for the overall progress on SDG 16.9 and 17.19. Except for India and Bangladesh, the death registration uptake is abysmally low in the remaining 4 countries. When it comes to medical certification of causes of death, all 6 countries need to pay more attention, because that's a cause of concern, including in India, where the cause of death, has been hovering around 20-22% for last 2 decades. As things cannot move without funding, so the working group reached out to GFF and Global Fund for a potential collaboration. The feedback so far has been very positive, and we plan to convert this collaboration into action in 2024. We will keep you updated. On the production of global goods, we released an addendum to the WHO UNICEF guidance on engaging with the health sector. The addendum has has examples beyond notification and declaration, and has examples of countries embedding birth registration services in maternities and immunization desks. An e-learning course on the role of health sector for improved birth and death registration programming was also released. Continuing with our technical support, the working group reviewed the mortality reports in Tanzania. Can we go to the next slide? So our plans for 2024 and 2025, we are going to actively engage with Pakistan and Ethiopia, besides providing our usual support to other countries. Please feel free to reach out to us, if you need our support. And the working group is in touch with UNICEF Regional Office, Wakaro, West and Central Africa, because they have started an excellent initiative called Reach the Unreached. And this is a collaboration between child protection, health, technology for development, and data and analytics. And the idea is to bring synergies between birth registration and immunization, especially 0 dose. In phase 1, there are 6 countries: Cameroon, Chad, Cote d'Ivoire, Nigeria, Mali, and Guinea. And talks are on to include death registration also as part of this process. And of course, we are here to identify countries to focus for the next 2 years. So please feel free to reach out to us. Doris and I are available for a one-on-one meeting if you want. The working group is also in the process of revising UNICEF WHO joint statement with more partners such as Vital Strategies, CDC Foundation, etc. And we are also exploring the potential for a peer-reviewed article to reinforce our case. We will continue engaging with countries for safe, innovative, and cost-effective digitalization, which is in sync with the improved business process. This is one area that merits immediate attention because countries want to digitalize business processes that are of 80s and 90s. So consequently, what happens? Digitalization becomes a barrier instead an enabler. We also want to emphasize that the cost of digitalization should not be passed on to clients, either directly or indirectly, especially for registration and for the first copies of birth and death certificates. Unfortunately, several countries, including Kenya, are moving in that direction. We are engaging with such countries, and we're hoping that we will find a solution. We are looking for a modest budget of $1 million for 2 years, and we are hopeful that we will manage to get the funding. And I think with this, I'm done. Thank you.
Thank you very much for your presentation, and very informative. And then we'll move to the routine health information system working groups. Ayub Manya from Kenya, Ministry of Health. Next one.
Yeah, good morning.
This side.
Today I'll be presenting on behalf of the Routine Health Information Systems Technical Working Group. I'm one of the co-chairs. We are 3 of us, and I'm the only one who came. Not because I came, but because I live here, maybe. Can we move to the next one? So we are all aware that we are witnessing a lot of improvement in our routine health information systems, and all countries are doing their best. And this is partly due to the advanced technology. We are all aware that digitization is the key to everywhere. And it could also be due to the fact that people are seeing the importance of routine health information systems in being able to monitor their targets, to monitor their programs, and being able to use the information to make certain plans. So the importance of routine health information systems cannot be underestimated. So it's there, and we are realizing that. But we know that despite all these improvements, the countries still think there are certain problems. For example, people mention poor data quality. They also say people are not using the data, they're not demanding it. And so we actually end up being described as being rich in data somewhere, but really poor in information. We collect, and maybe the idea of information use is not really coming out. So in our short meeting, we thought we should really concentrate on reviewing the health facility and community-based routine health information systems to see how their standards are harmonized. We look at some of the best practices and the protocols and tools. And if there is any good country, we need to document and actually share with each other what could be happening, because there could be some countries that are really doing very well and others are not doing very well. But so we need to look at that. So those are some of the aims that at the end of maybe next year, we should have actually looked at some of this, reviewed the countries and seen where we can copy a leaf from. The next one. We don't have a lot to boast of in the last 1 year, but we've done some work. For example, we had a meeting in Athens last year where we reviewed the score. And I think when it is finally done, we'll apply this score. They talked of 2025 maybe. And also we completed our 2022, 2024, 2025 work plan. And every month we hold regular meetings. And in some of these meetings, we get presenters from various countries to tell us some of the benefits and some of the best practices. Some people really present to say that maybe when we hold regular review meetings, people are able to use the data. Others talk of ways of presenting data in maybe bulletins, and that maybe spurs the use of routine health information systems. And all these are normally packaged every month. Once in a while, we get a person to speak of best practices. And if we can harness all these best practices, our team can actually come up with recommendations on how well to spur information use in this era where we have a lot of data and very little information coming up. Next. So we came up with some priorities. There are quite a number, but sometimes when you go out, you shouldn't present all your problems. So we just gave a bit, 1 or 2 areas that we might think if we concentrate on that, we'll have an improved information system. So number 1, we thought we could carry out a routine health information capacity building program, which is tailored at maybe one of the HDC country with the support of a regional institute alongside a national institute. So like we need, that's a bit of training, and in this we may share documented lessons learned at the capacity building program at the regional meeting for the HDC community to stimulate peer meetings. So meaning the next time we meet, if we'll have done this, we can actually share how it worked. And we were a little bit modest. We think if we got $200,000, maybe that would be suffice. The next activity we were thinking is more like case studies on good data use in a district or a selected country to institutionalize best data use practice, e.g. the routine data use meetings. There are some countries which have regular or quarterly data review meetings where people present their data from their districts. And in one of the meetings I attended, actually somebody put up their hand and said, no, this is not our data, because maybe it got corrupted in the system. And this gives you a chance to learn from each other that sometimes data quality is maybe a reflection of just mistakes in entering, which can be rectified. Could also be the fact that people are beating a deadline because in some reporting situations, we aim to have regular reporting. One of my interesting stories that we want to have monthly reports, yet the data is actually not used monthly. And in that case, maybe there would be a chance to revise our reporting rates to reflect on the use, because when you quickly get your reports on a monthly basis and then it will lie there until at the end of year when you do your annual report, then you wonder why you are rushing to present the data, making mistakes, and then so there's quite a lot of lessons that we can learn so that we can change our mentality of regular monthly reports, weekly report, daily reports, and then finally it has reached the so what. And these are some of the areas we discussed, that when you have these regular meetings, we learn from each other and say, yeah, we were rushing to beat the deadline, so we made some mistakes, but we can rectify them. So these are the areas we can learn so that our routine health information system does not necessarily to be the old style where you every month you write, put in an envelope and send it to the national level. And also, we are also thinking maybe the idea of transmitting data is outdated. All we are doing is we need data to be in one place now that we're in the digital system, and then data is there, therefore doesn't need to be transmitted. And this transmission causes a lot of data quality issues. So with the digitization, we think that would also be a wonderful way of having data in one colleague here said in a silo, in one box, and me I say one pot, where now whoever wants it can be able to pick and use, instead of saying this month's package and send. So these are some of the these meetings. If we can do 1 or 2 countries and see the value of that, we can also do one of the areas we're thinking, one of the best practices is having data analyzed and put in a format that it can inform policy. And when that is analyzed and kept, then people can actually use it to say, we've realized the HIV level is going down, and therefore we can change some of the messages we send to people. And that is based on the data. But if we are just having data they are not even analyzing, maybe that may not bring any policy change, and people will be doing the same thing without any, because we don't have the data and are technically waiting for somebody from outside to tell us, I think COVID is now over, or I think HIV is now over, yet we have data that we could actually utilize, analyze, and show. So those are some of the areas we propose. Regular meetings, we also propose being able to analyze data and present it in the format that maybe can make some information. And the other best practice is having a portal. You know, we've got our repository, which we've done, but we hardly put the data in that portal. So having a practice where we analyze data, put it in the portal for people to see. And that will actually eliminate all these many problems of people writing to the Ministry of Health asking for data. We would just direct them. Certain basic data is available at that particular website. They can consume it, but if they need more, then they can ask for more details. So these are some of the things we are thinking as best practices, that if we get some little seed funding, would be just maybe 50K per county, by country. And we had support, we had thought of course, I know you know one of the countries that is supposed to, will be the first one to do this, and that is Kenya. Yeah, it goes, they say it goes without saying, you have to love your neighbors, you love yourself, isn't it? So we start with Kenya because I'm in that working group. Maybe Tanzania is also there, Uganda can come in, and there's quite a lot of talk about Laos. I don't know what is so special there. I don't know where it is, but I think it's also one of the areas that we can learn. So if we get 4 countries and get some little funding, we can think of some of these best practices that we can now show to the world that if it's done this way, we might improve. The other next slide is the third one. It's been on our mind about knowledge brokering. And this is actually, if we can think of, you contribute to the animation of a network with a resource center where countries can access global routine health information reference documents and country-specific documents. Like, for example, if we put there where you can get all these documents. We could also plan things like regular webinars. And we say if we do it very well, actually, we can also give it to the other working groups. So we are really thinking of a center of excellence where we can have materials, we can have regular webinars, and all of us can be asked to contribute something to that particular knowledge place. And what do we really need for this? I think we just need one person to keep the online library up to date and organize. And that's a very hard job. I've once tried it. And it's like when you are writing, you know, in the old days, I can use the word in the old days, we had what we called the newspapers, the daily newspapers. I think there's a particular time you must be through with it before the following day. And also this, you also need to be fully aware that every now and then you update, and it's a full-time job. And if you just got on holiday, people will be calling you, we've not seen the data yet. So that is one person. We also think could have an editorial team committee, which could be made up of members of the working groups. And of course, we need a space, and that's our website, or sometimes it can be expensive. So we are just being conservative that we got 100,000, maybe to be able to regularly pay this person, pay for the space, and then maybe some allowances or some money, not for the editorial group, maybe when they have a meeting like that. So these are some of the thoughts about our routine health information system working group. And I think that was the last slide. So I just want to thank you for listening and welcome you on board in trying to see that the data we collect goes somewhere. Thank you.
Yeah, thank you very much for the update on this routine health information system working group. And there's a slight change in the agenda. We will go to the Cambridge Wellcome Trust Institute presentation. Anthony Etang, Head of the Epidemiology and Demography, Cambridge Wellcome Trust, over to you.
Thank you, and thank you for accommodating my request for unavoidable circumstances. So I'm Anthony Etiang. I'm a physician and epidemiologist, and I'm head of department of epidemiology and demography at the Cambridge Wellcome Trust research program. Thank you for inviting me, and I'm going to give just a short presentation whose aim is to demonstrate the expertise and the platforms that we have available as a research institute, and how by partnering, which I think is one of the major objectives of the Health Data Collaborative, we might all be able to achieve or align our interests and achieve our objectives. Next slide, please. So I'll start by talking about one major research platform that we have, which is the Kilifi Health and Demographic Surveillance System. So this is a health and demographic surveillance system that has been running for over 30 years on the coast of Kenya, an area of around 900 square kilometers with a population of about 300,000 people. So we regularly enumerate the individuals at this within this study area 2 to 3 times in a year. We collect data on vital events: who has been born, who has died, who has moved in, who has moved out. And we do this 2 to 3 times in a year. And the data are linked to admission data at the Kilifi County Hospital. So if a resident of the Kilifi HDSS gets admitted to Kilifi County Hospital, we're able to link that data, and so we can get very accurate incidence
of various diseases and examine various interventions when they have been introduced, various public health interventions. When these patients get admitted and they get lab tests conducted, that data from the lab data, the results are also linked, and it's a major effort. The picture doesn't really convey or demonstrate or illustrate properly how much goes into doing this kind of work. So we've got a dedicated IT department and people whose only job is to make sure that this data are linked and making quality checks. So using this platform, we've been able to answer numerous important public health questions. So for example, these are just a few that I've listed there. So for example, Kenya has suffered, as with many low and middle income countries, many healthcare worker strikes, and nobody really knew what the impact of these strikes were on mortality at a population level. So because we've got this linked data, we've been able to examine the effect of these strikes on health outcomes at a population level. Now, RSV is one of the major causes of childhood pneumonia, and there are discussions about introducing a maternal vaccine. But before the vaccine is introduced, we need to know at what time or what are the patterns of antenatal clinic attendance for pregnant women. And again, using this platform that we have, we've been able to look at the implications of gestational age at antenatal care attendance on the implementation of the RSV vaccine program in Kenya. Then around 2011, Kenya introduced the pneumococcal conjugate vaccine into the childhood immunization program. As it was being introduced, there was concern that because the vaccine was only covering about 10 serotypes, I think it's expanded to maybe about 13 now, and there are more than 90 serotypes of Streptococcus pneumoniae, that there could be risk of serotype replacement disease. So we were able at a population level to determine what the impact of the introduction of this vaccine was. Now, the other thing about the DSS, which I'll demonstrate in the next slide, please, is that oh, sorry, it will be on the next one, but we'll stick to this one. Yeah, I'll refer back to the DSS in the next slide. So the other platform that we have is the clinical information network. Now, the clinical information network is actually a collaboration between researchers at the Kemri Wellcome Trust Research Program, the Kenya Pediatrics Association, and the Ministry of Health in Kenya. It's been running since around 2013, and initially started and is best known for work in the pediatric wards. But from around the start of the COVID pandemic, because of a request from the Ministry of Health in Kenya, we were able to expand the activities to include admissions in the adult wards because there was a particular interest in the pattern of severe acute respiratory infections among adults. So what we do within the CIN is routine clinical data that clinicians enter in the course of their clinical care of patients admitted to about 21 public hospitals in Kenya. This data are captured, and there was an initial process in the pediatric wards to develop a standardized admission record, so that as a child is being admitted, there's a standard set of data that need to be collected on each and every child. And there was very good cooperation as this form was being developed, and it's been adopted at all of the hospitals. So having this standard form, then the data are entered onto a simple REDCap database, which is then synchronized with a server at the Kemri Wellcome Trust, and we've got automated scripts that do quality checks and then the data are fed back to the hospital. So I had, listening to some of the conversations here, one of the challenges that we have in collecting routine data is that the frontline workers sometimes don't see why they need to do all of the documentation that they're being asked to do. But by feeding back the information that they themselves have collected and showing them the trends in some of the clinical parameters of what they're doing, then they're able to see how they're performing and actually improve care. So simple things like what proportion of patients had their vital signs taken, was a temperature taken, and we feed back the information to the hospital administrators, and then that automatically triggers, if you could call it an investigation within the hospital. The administrator will say, well, I bought so many HIV test kits. How come I'm seeing that we only tested 2% or 10% of our patients for HIV? And without any further intervention, we actually observe an increase in the number of tests or vital signs or whatever indicator of quality of care that is provided by the hospital. So that kind of positive feedback generates demand by the care providers, and they see a benefit of participating in this data collection, while at the same time the data can also be fed, can be shared, and are shared with various stakeholders so as to monitor various public health interventions. That said, we are researchers, and we also use this platform to answer research questions which are of public health importance. So some of the public health questions, research questions that we've been used to, we've utilized this CIN platform to answer are, for example, what is the feasibility of introducing the RTSS vaccine in routine settings? And we used in Kenya, I think it was done in several counties in Western Kenya. So we were able to use this platform to answer that question. At the same time, we're looking at whether conducting clinical trials, looking at antibiotics and supportive care, what combination of antibiotics and supportive care are useful for children with severe pneumonia. We're also using it to monitor patterns of antimicrobial resistance and how we can scale up surveillance. So one of the studies, for example, is looking at a hub and spoke model, because it's considered not so feasible to have high-level laboratories at each of the sites. So can you have some hubs which can do high-quality microbial surveillance, and they the spokes can send their samples to those sites? Then we also used this platform to look at the effect of the COVID-19 pandemic on hospitalization and inpatient outcomes. Final slide. Actually, it's the penultimate slide. So then we also at KEMRI have a big, this is a point I was trying to make about the expertise and research teams that we have. And one of the work streams that we're doing is looking at how we can strengthen civil registration on vital statistics. Now, it's recognized that to deal with this problem, there are multiple challenges across various at various points. So so we're doing a combination of qualitative as well as quantitative studies that will help inform efforts to improve CRVS. And to do this, one of the things we are looking at is just determining, for example, what's the accuracy and completeness of the currently recorded data in the CRVS. And we're able to do this by comparing what is in CRVS and the gold standard, what we're calling the gold standard, which is the DSS data, which I talked about in the first slide. So we're able to compare the CRVS data with the HDSS data. Then we look at what are the barriers at the community level to recording events, especially deaths and registration of deaths. And At the same time, we're looking at whether the use of CHWs can improve the collection of events in the community. As well as causes of death, including verbal autopsy. So this is an ongoing piece of work. Final slide. Yeah, so summary and challenges that we are facing. So we continue to work with the Ministry of Health and various stakeholders to generate, analyze, and interpret health data for understanding disease burden, to evaluate the impact of interventions, and also improve the quality of care. We've got highly qualified personnel that can provide technical support for collecting, interpreting, and analyzing the data. However, research is costly and research funding is scarce. We're always looking for grants all the time. But we think that if we can partner with various organizations, for example, that are implementing different programs, we can embed research components and take advantage of the expertise that we have within the research institute so that we're able to serve the multiple interests that are represented in the partnership with the ultimate aim of improving the health of people in our countries. Yeah, so that's it from me. Thank you.
Thank you, Anthony, for the research update from the Wellcome Trust. And next we'll move to the again to the working group presentation. And next presentation from the community data working groups, Pandul Srivardhana, SDG Secretariat on behalf of the working groups.
Good morning, everyone. So I'll be presenting on behalf of the Community Data Working Group. Can we move to the next slide, please? So the Community Data Working Group has 3 key objectives that they have defined and are working along these lines. Firstly, in terms of enhancing, aligning and coordinating, collaborating across stakeholders, particularly with a focus on community health data and systems for health. Secondly, it's about optimizing, harmonizing, and promoting standards, guidance, and tools, again, with a focus on broad HMIS, integration with broad HMIS and information ecosystems. Thirdly, it's about capacity learning and building on country community data and system efforts that are already there, and supporting frontline community health workers in terms of service delivery and enhancing population health. Shall move to the next slide, please. So there are several achievements that have been illustrated here. Firstly, the 3 short guides that have been developed. Firstly, about training material to support capacity building for indicators and standardization. Secondly, guidance on steps to develop community health information systems. And thirdly, learning about best practices on data use at the community level. Next slide, please. And there was a publication also with Johns Hopkins. It's about reimagining the future of community health, the role of community-based information systems. And I think based on this, as well as based on the expertise, can we move to the next slide, please? There have been 2 key workshops arranged with a focus on community health information systems, one for Anglophone countries with 16 countries taking part. Next slide, please. And another for Francophone countries with 9 countries taking part, all taking place in during 22-23 period. Next slide, please. The contributions by the Community Data Working Group also led to the panel at the Global Digital Health Forum in 2023. And along with Johns Hopkins experts, the panelists discussed on digitizing of community-based information systems. So it is another achievement during that period. Next slide, please. So for 24-25, the working group have illustrated these key deliverables along the lines of mapping of digital systems with a particular focus on community data, understanding where the countries stand and the gaps. Then also to convene as a learning exercise, face-to-face community data forum, where the digital health, where the topics in terms of how health may be transformed through digital interventions, particularly with a focus on community data monitoring, will be discussed. Thirdly, the panel that is proposed for at the Global Digital Health Forum, along with John Hopkins, that is another proposed activity, and also a community health worker registry that is actually linking up with the proposals from Kenya. That is also being included in the deliverables, and this is basically linking up with the country requests. I'm sure these will get expanded further as the country requests come through. I think those are the only slides. Next slide. Yeah, so that's a brief update from the community data working group. Thank you.
Pandula, please be there, because as Manish Kumar is not available online, Secretariat has kindly requested you to present for the next.
So I have become the spokesperson for the working groups. So the next one is digital health and interoperability. As you can see, three key objectives that they have undertaken. Firstly, in terms of optimizing meaningful use and reuse of health information technology in LMIC contexts, with a focus on SDGs. Then in terms of promoting development use and long-term support of digital health as a global public good, and then focusing on increasing in measurable ways level of alignment of country and partner investments in support of objectives 1 and 2. Next slide, please. There are 9 functional sub-working groups within the digital health and interoperability working groups, focusing on AI, country engagement, diversity, equity, and inclusion, digital health capacity strengthening, classification review, maturity models, privacy and security, digital health and supply chain, and digital health and climate change. Based on their work, there have been several achievements that have been illustrated. Next slide, please. So among the progress and key achievements, with regard to digital health and capacity strengthening, as you can see, there have been several activities listed. Firstly, the support of the delivery of digital health planning national systems course, and it has so far has trained more than 300 digital health personnel up to the September 30th. So I'm sure these numbers probably have expanded further. And also the working group has contributed to the digital health competency framework that has been I think has undergone consultancy phase and now is in the process of being finalized. And then with regard to sub-working groups participating in Oasis Forum, that was promoted by ITU with a focus on capacity strengthening and activities around the table with WHO and ITU. With regard to country engagement subgroup, there are several countries that have actively engaged, including Tanzania, Kenya, and Zambia. And then engagement with partners and the donors, aligning them with the principles of donor alignment for digital health, which basically aligns with the objective of investments that the group is undertaking. Next slide, please. With regard to the maturity models, the 3 main activities were listed: promotion and coordination of navigator and different types of dashboards and tools, including Global Digital Health Monitor, DPP, and the WHO Digital Health Atlas. And also with regard to contributing for this global fund countries at the GDHM, and also supporting in the implementation development of global global digital health index, and also the deliverable that was launched at the GDHM, I think at the sidelines of the World Health Assembly in May. Next slide, please. So the work plan for 24-25 and the resource requirements highlighted here, focusing on developing a handbook that will guide LMICs in their digital health supply chain transformation. Then with regard to supporting capacity development around digital health, the focus again, another publication on how digital health can reduce the environmental harm of the healthcare industry as a whole. And then focusing on evaluation and reorientation, how the working groups actually aligns with the changing needs within the global digital health environment. Is there another slide? I'm not sure. No. So that's a brief with the global digital health and interoperability working group. Thank you.
Thank you, Pandula, for summarizing all these important areas from these working groups. Now we'll move to the partner institutions presentations again. Yeah. Institute Dakar, Senegal, presenter Keik Lokuba, Head of the Epidemiology, Clinical Research and Data Science Department.
Thank you. So if you allow me, I would like to present in French. So, and it will help my French colleagues. Voilà, donc voilà, je suis Cheikh Lokoubar, donc je travaille à l'Institut Pasteur de Dakar, où je suis le responsable de l'unité d'épidémiologie et de sciences des données. Prochaine diapo. Voilà, je commence d'abord par vous présenter un peu le réseau Pasteur. Donc, l'Institut Pasteur fait partie d'un réseau de 33 instituts qui sont un peu représentés, comme le montre sur la carte, à travers l'Afrique, l'Asie et un peu en Amérique, donc présents dans 26 pays, avec plus de 23 000 personnes qui travaillent sur l'ensemble du réseau. Prochaine diapo. Voilà, donc pour les données, on a beaucoup de challenges concernant la donnée, l'accès et le traitement des données. Donc, on peut voir par exemple l'accès en temps réel ou quasi réel à des données, et ça, c'est spécifiquement durant les urgences sanitaires. On a vu ça durant Covid, où il fallait rapidement avoir accès aux données, rapidement les traiter pour guider les prises de décision. Une fois qu'on a accès aux données, il y a encore d'autres problèmes. Par exemple, le problème de la qualité. Ce n'est pas garanti que la donnée est de bonne qualité. Il peut y avoir beaucoup de données manquantes et aussi des incohérences. Donc, il y a cette étape de traitement. Une fois qu'on a accès aux données et que c'est de bonne qualité aussi, il y a un problème surtout d'Internet, couverture Internet dans un pays, par exemple. Si, par exemple, l'épidémie, situation d'épidémie, par exemple, où il y a beaucoup de districts qui sont touchés et dans des zones où l'Internet n'est pas très bien connecté, on peut avoir aussi un retard dans l'accès des données. Le problème aussi pour mettre en relation l'ensemble des parties prenantes, les gens du terrain, les laboratoires, les gens qui sont au niveau du ministère de la Santé, les partenaires, tout ça. Donc, tout ça aussi, c'est des problèmes qui se posent en cas d'urgence sanitaire. Et aussi tout ce qui est réglementation dans le partage des données. Voilà, tout ce qui est réglementation aussi, ça, c'est à voir. Et aussi, comment aussi mettre une infrastructure qui permet d'avoir aussi accès et de connecter les autres types de données. Parce qu'il y a d'autres données aussi qui peuvent être connectés aux données de santé humaine, par exemple les données du secteur animal pour une santé globale. Donc tout ça, c'est des plateformes sur lesquelles les gens réfléchissent. Et aussi comment automatiser tout ce qui est analyse des données et reporting. Voilà, donc tout ça, et ça, c'est qu'une partie des problèmes qui se posent en ce qui concerne les données. Prochaine diapo. Donc ici, je donne l'exemple un peu au niveau de l'Institut Pasteur de Dakar, au sein de notre équipe. L'appui que nous faisons pour les pays de la région et surtout les pays de la région CEDEAO. Donc ça, nous le faisons en collaboration avec l'Organisation Ouest africaine de la santé, WAHU, qui est l'organisation de la santé au niveau de la CEDEAO, ECOWAS, où nous avons donc un outil, une plateforme digitale au niveau du Sénégal qui nous permet de connecter le terrain, l'unité, les épidémiologistes, les laboratoires et les gens qui prennent les décisions. Donc, il y a des formulaires électroniques qui sont développés et qui sont disponibles sur tablette, qui sont répartis au niveau des structures de santé qui sont sur le terrain. Quand les données sont collectées, les épidémiologistes, les analystes de données peuvent avoir accès aux données et pouvoir faire des cartes et des graphiques, des tableaux qui sont partagés après sur une plateforme qui permet aux gens, aux responsables, en tout cas les gens qui suivent l'événement, les gens qui peuvent être au niveau du ministère de la Santé, au niveau aussi des instituts de recherche. Et pour le cas de COVID, ça c'est quelque chose qui a été développé avec COVID, ou qui était même connecté à l'aéroport pour les gens qui voyagent et qui doivent effectuer des tests. Et ça leur permettait d'être connectés sur la plateforme pour être sûr que le test est un test véridique. Voilà, donc ça, c'est en train d'être mis dans quelques pays de la CEDEAO, donc avec l'appui de l'Union africaine et de WAHU, c'est en train d'être mis dans les 15 pays de la CEDEAO avec une phase pilote qui a commencé avec quelques pays comme la Gambie, le Cap-Vert et la Mauritanie. Donc actuellement, les équipes sont en train de déployer cet outil au niveau de ces pays. Donc ça, c'est quelque chose qui permet de centraliser la collecte de données et de le repartager entre les parties prenantes. Voilà, prochaine diapo. Il y a aussi un autre outil qui est en cours de développement et en phase pilote, donc qui avait commencé en 2019 et qui a été un peu stoppé durant Covid, mais qui a été repris et qui permet de connecter les labos de référence qui sont au niveau de la région CEDEAO. Donc, c'est un outil West African Laboratory Network Data for Data Sharing Platform, WALIP. Et donc, ça, c'est un outil qui permet de connecter, parce qu'avant, les labos de référence dans la zone Afrique, en tout cas dans la zone CEDEAO, avaient qui participent à la surveillance des maladies, donc avaient une façon de partager les données de façon hebdomadaire. Donc, chaque semaine, ils envoyaient par email avec un fichier pièce jointe, un fichier Excel, qui avait des données agrégées qu'ils envoyaient au niveau du responsable de la surveillance qui est au niveau du ministère de la Santé de leur pays. Ensuite, les responsables de la surveillance qui sont au niveau du ministère de la Santé repartageaient ces données au niveau de l'Organisation ouest-africaine de la santé, aux responsables de la surveillance. Donc, il y a eu un support donc, de WAHU pour créer une plateforme digitale qui permet de regrouper l'ensemble de ces acteurs. Chacun donc a un compte d'accès sur WALIP et qui leur permet de partager les données en temps réel au lieu d'utiliser des emails avec des pièces jointes. Donc, quand les gens du labo ont des détections, ça peut être des maladies comme la fièvre jaune, rougeole, en tout cas les maladies, les pathogènes d'intérêt qui sont sous surveillance, ils peuvent, si le labo valide, cocher les pathogènes qu'il veut, faire l'agrégation qu'il veut et pousser les données vers son ministère. Et chaque ministère aussi est autonome de partager ce qu'il juge validé autant qu'il faut au niveau de l'OAS. Donc ça aussi, c'est en phase pilote au niveau de 4 pays, Niger, Burkina, Côte d'Ivoire et la prochaine étape, ça va être la Gambie dans quelques semaines. Et donc, l'objectif est, après cette phase pilote, faire une évaluation et voir s'il faut faire aussi un scale-up au niveau des labos de référence qui sont dans la région CEDEAO. Ah, donc ça, c'est des supports que l'Institut Pasteur de Dakar apporte en termes de données et d'outils de partage de données au niveau de la région ouest africaine. Et que donc ça peut être mis à disposition, en tout cas, ou discuter, échanger sur les façons de faire, partage d'expérience avec HDC et sur d'autres thématiques aussi. Voilà, prochaine diapo. Voilà, comme je disais, l'objectif de Wahoo sur ce projet-là, c'était pour faire la promotion de la coopération et de la communication entre les labos de référence et aussi supporter une transmission rapide des données de bonne qualité. Et aussi, que ceci permettra une détection rapide. En tout cas, dès que les labos ont des résultats, ça va accélérer tout ce qui est reporting au niveau des organismes qui sont responsables de la surveillance dans les pays. Ça permettra aussi de faire chaque semaine une cartographie des urgences de santé publique dans la région ouest africaine. Ça fait aussi la promotion en tout cas, ça supporte la réponse aux épidémies et ça permet aussi d'identifier les souches de pathogènes qui circulent dans la région et qui peuvent enrichir les biobanques. Prochaine diapo. Next. Voilà, en termes de support que l'IPD pourrait apporter, en tout cas pour les partenaires de HDC et les pays, c'est en termes, donc c'était en 3 rubriques, en termes de, en tout cas, advocacy sur les données, donc l'accès rapide aux données, tout ce qui est accès en temps réel, donc nous faisons ça pour le ministère de la Santé du Sénégal, donc pour le pays, pour le Sénégal, donc l'IPD a l'habitude de faire ça depuis des années, donc c'est quelque chose sur lequel l'Institut peut appuyer. Aussi tout ce qui est communication sur l'importance de la qualité de données, la cohérence, l'exhaustivité et la représentativité des données. Tout ce qui est aussi sur gouvernance des données, comment on stocke les données, où les stocker, comment avoir accès de façon sécurisée, quelles sont les règles d'accès, etc. Donc ça, c'est des choses que nous avons de l'expérience avec le Sénégal et quelques pays qui sont à côté du Sénégal. Et aussi, quand on dit partage des données, il y a aussi des problèmes qui se posent au niveau de la valorisation, parce que toutes les personnes qui sont impliquées dans la mise en place de la donnée, en partant des gens du terrain qui font la collecte, les gens qui font la gestion, nettoyage, contrôle qualité et complétion, tout ce qui font l'analyse et le reporting, comment on va valoriser chacun. Donc ça, c'est des choses sur lesquelles nous avons eu à travailler et même à travailler pour une organisme africaine avec d'autres experts qui sont dans ce domaine. Et donc, c'est des expériences qui peuvent être partagées. Et comment aussi on supporte. Donc, tout ça, au fait, voilà, c'est pour supporter la prise de décision qui est basée sur des évidences scientifiques et qui est basée sur des données. Un autre domaine aussi sur lequel on peut appuyer, c'est tout ce qui est la formation des gestionnaires de données. Tout ce qui est aussi formation des analystes de données, de statisticiens, de modélisateurs mathématiques que nous avons dans nos équipes et qui ont aussi l'habitude d'intervenir dans les universités du Sénégal, dans des masters spécialisés, donc qui peuvent partager leur expérience en termes de formation. L'Institut Pasteur aussi organise souvent des formations régionales pour l'Union africaine et pour l'OMS au niveau de Dakar. Et donc ça peut être de l'expérience qu'on peut repartager. Tout ce qui est formation d'informaticiens pour la santé, voilà, pour développer les dashboards, etc. Et dernièrement, donc, l'autre support qu'on pourrait apporter aussi, c'est en termes d'investissement en infrastructure, voilà, les infrastructures modernes, avec de la sécurité qu'il faut. Et quels sont les investissements prioritaires? Ce n'est pas que de l'investissement matériel, il y a aussi de l'investissement en termes de ressources humaines, en termes de conseils, expertise, voilà, et aussi tout ce qui est des solutions techniques pour un système d'information sanitaire. Voilà, prochaine diapo. Voilà, donc valeur ajoutée pour HDC. Donc, je suis le template qu'on nous avait envoyé. Donc, c'est tout ce qui est apprentissage, échange de connaissances et co-collaboration entre les partenaires au niveau de HDC. Et les besoins que nous, en tant qu'institut régional, qu'on voudrait à travers HDC, aussi c'est support sur tout ce qui est aussi législation, d'appuyer sur ce volet en termes de données, surtout quand ça concerne des données à travers plusieurs pays. L'accès aussi à de la ressource de stockage et des ressources de calcul, de plus en plus maintenant sur le cloud, ou aussi de l'investissement en infrastructures locales qui peuvent être au sein des instituts. Donc ça aussi, c'est des pistes sur lesquelles l'Institut cherche toujours des partenaires qui les appuient là-dessus. Voilà, merci beaucoup. Je pense que c'est la dernière diapo.
Thank you, Keik, for updating about the very important piece of work on sharing the laboratory informations across the countries. Now we come to the final presentation. That's Preeti Nigadi from Indian Institute of Public Health, Delhi.
Thank you. Good morning once again, everyone. I am Preeti Nigadi, an additional professor at the Indian Institute of Public Health, Delhi. Before I move to my next slide, I just want to give you a quick introduction to the institute that I belong to. The Indian Institute of Public Health, Delhi is an academic institute under the aegis of the parent organization Public Health Foundation of India, which was launched in 2006 with some seed funding from the Government of India, bilateral agencies, and other international universities and academic institutes. We are primarily an academic institute. We have other sister institutes in other parts of the country. We are based in Delhi. We offer master's programs in public health, clinical research, and we have a portfolio of e-learning programs as well. So that's our primary mandate. In addition to that, we also offer short-term trainings for public health professional students across India and also other neighboring countries. We've done that in the past, over the past almost 7-8 years now. So a lot of my time and my colleagues' time is spent on teaching the students of public health. But we also spend our time on research, and some of it is spent on health information systems. Next slide, please. So as far as our engagement in HIS is concerned, we started out around 2014-15 with some partnership with Measure Evaluation, which was then based at the University of North Carolina, and with WHO CRO. We were engaged in the PRISM assessment in a couple of states in the country, and the launch of the South and Southeast Asia RHIS network. These were some of the activities that we were involved with. But one of our major activities which we conducted within the PHFI Institute with Measure Evaluation, JSI, and WHO CRO was the piloting of the RHIS Basic Concepts and Practices curriculum. This was done over a period of 2 weeks within the PHFI premises in 2016, following which we standardized this global curriculum, which is currently available in the public domain for people to take up as part of the capacity building initiatives. So that is something I'll be talking about in my next slide. But in addition to that, some of our in-house activities have included the profiling of the health equity for India. This is something we've recently completed with WHO Country Office for India. And we've also conducted some data usage workshops at subnational level within Indian states. Like Dr. Ayub mentioned, even within India, there are certain states that are doing very well with data use, data demand analysis, but then there are others which have limited capacity. So we've been helping them out based on requests coming in from the state governments to build their capacities on data analysis, data demand, data usage, etc. Next slide, please. Coming back to our RHIS work, After the curriculum was standardized and was available for global use, we've conducted 4 workshops. The first workshop was conducted on the request of the Ministry of Health, Government of Maldives. This was in 2018, where we actually visited the country. We stayed there for 2 weeks and we conducted the workshop for their HIS officials. After this, we were busy with the score assessment for the Southeast Asian country. So that took up most of our time in 2018-19. And we published that paper as well along with WHO CRO colleagues. In 2020, we were to do a second workshop, regional workshop in Bangladesh, but then COVID struck and we couldn't do an in-person workshop since. We have conducted regional workshops virtually. We've conducted 3 workshops virtually. These have been regional workshops using the same standardized curriculum. In Maldives, however, we were able to customize it. So Maldives had a very specific request. They had issues with data analysis and use. So the request came in from their side. They wanted us to spend more time on that particular module, which we did. We had to customize some of the materials for the same. So that sort of capacity is available at the Institute. And personally, if you ask me, the in-person workshops have definitely better value in terms of the learning outcomes as compared to the virtual workshops. But then there was no alternative. We had to conduct them virtually during the pandemic. We've also conducted the routine data quality assurance workshop in Nagarkot way back in 2016. This was just some of our other, just to highlight that we've also been conducting trainings on those fronts. Next, please. So in terms of what we can support HDC and the countries and even regions moving forward is to continue conducting the workshops for the countries that we have been doing it. We can do it for the new countries that have come on board. We can do it through HDC. We can do it with the support of WHO regional office. We have been engaging with the WHO CRO regional office quite regularly. And you know, as I said, personally, the in-person workshops are better, but if there is no alternative, we can go in for virtual workshops, customized virtual workshops as well. We are an academic institute, so we do rely on grants and funding support. So that's one thing that we would need if we had to go ahead with conducting the workshops. Dr. Ayub did mention the need for more capacity building in data quality and understanding data quality, data analysis, data use. We could definitely, I and another colleague of mine, Anjali Sharma, are part of the RHIS working group. So we could definitely be the regional institute he was mentioning, which could support countries in building their capacities in that area. Thank you very much.
Thank you. Now it's the time for the feedback and Q&A session. And actually, we have listened to many presentation from working groups and partner institutions, regional institutions. And I suppose now countries can give their feedback on how they would like to see in future working with the working groups and regional institute, and what are their opinion, what are the challenges they face in communicating with them. And now the forum is open for questions for the countries. Shall we start from that side? Yeah, please.
Yeah, thank you very much for the opportunity, and many thanks to the presenters. I think they've given us a very good oversight of what really what they are actually doing in their countries. And I think the working groups, the technical working groups, are great opportunities for countries to learn from one another. And I think South Sudan will harness that opportunity and try and collaborate with most of the technical working groups that are existing. On the issue of data use, like I would like to quote from the presenter from Kenya, who said that we are rich in data but poor in information. That's very true. We really do have a lot of data available in most of our area of work. However, we do shortfall in making the data to be used. And what I do think is that the HDC can help and support the data to be translated into utilization is by encouraging the use of or hosting data review and action meetings that are chaired by the top leadership of the ministry. I mean, I believe if we can advocate for meetings whereby the senior leadership of the ministry are actually chairing those meetings, they will have the opportunity of bringing the programs, the respective programs, to come together and make basis of the information that were derived from the data that has been generated. And on the presentation from our colleague from Senegal, I think he demonstrated that the lab is a very important component on surveillance. I would like to ask him the lessons learned or the best practice they can share in terms of supporting countries to be able to use the reference laboratories within their region, because I can see that the lab they are having in Senegal is helping countries within the West Africa bloc to be able to identify strains of pathogens and within the region. But then for FCV's countries, like for instance South Sudan, we're trying to strengthen our lab, but many a times we do require to send or ship the samples collected from the country to reference laboratories within the region. But sometimes we are constrained with delays in getting feedback. Like the turnaround time is usually very long. Sometimes it takes a while before we are able to have feedback from the reference lab. So I don't know how HDC can further support in that, because sometimes we might be dealing with a contagious pathogen, and if we delay in getting feedback from the reference labs, it can definitely delay timely response, as well as not getting us the real time needed to act on, within the time required. I think I'll stop at that, and thank you once more.
Yeah, probably we can have a sideline discussion after after this session. Yeah, please. Yeah.
Thank you very much, Bantalan from Ministry of Affairs Ethiopia. Thank you all the presenters for insightful presentations, and we look forward to learning from the experiences, and we'll engage with you in discussions, and look forward to adopt some of the experiences. Having said that, from the presentations, I was expecting a group which would be focusing on foundational issues, like, for example, trainings for or curriculums for health information technicians or professionals. I wish there is a group which would be focusing on supporting countries or facilitating peer-to-peer learning in terms of producing the human resource, working with the academic institutions, and also I wish there is a group which would be focusing on supporting countries, or facilitating experience sharing in terms of implementing unique ID, master facility list, and data dictionary, and at the same time the human resource information systems as well. I'm not sure if the next groups would be focusing on this, or if these things are within the scope of the HDC. And the other issue that I would like to raise is with regards to the public health emergency management information system. I see that the nature of health emergency would require a different kind of an approach in terms of reporting, and also informing immediate decisions. So I'm not sure if these things can be addressed within the routine health information systems, the TWG. I was looking for a separate team, because the emergency health emergency for information for emergency would require information from the community level, information from the laboratories, and information from the routine activities. So because of its nature, I would expect a different TWG, which would look into or explore any options or approaches to address the demands for the responding to the emergency situations. And the other issue is in terms of the RHIs, the RHIs TWG. Again, I was expecting to have the sub working groups within that, because it's kind of broad, including all the laboratory information systems, the HR information system, and also other sub TWGs. And I don't think we can bring or we can keep them together, all in one bucket. And I mean, suggesting to have the additional sub TWGs within the RHIs. I think these are the issues that I would like to raise. Thank you very much.
Yeah, thank you very much for your observations, please.
Okay, thank you very much. My first question is to the Civil Registration and Vital Statistics Working Group. How successful have the countries been in getting other ministries outside Ministry of Health, such as the Ministry of Planning, Ministry of Finance, and the national statistics, the different national statistics agencies in the countries, because they all need to come to the table. As health, we're not actually the main player in the space. And then for the routine information, and there was the request for resources to hold the different meetings. I am asking colleagues to actually talk to the WHO program technical. The technical people in the office, because programs such as immunization, HIV, they use a lot of data, and within the awards that we get, you can actually isolate funds to actually fund some of these meetings that the presenter talked about. And then with Kilifi County, very interesting cohorts that you're following. You said you've been following them for about 30 years now. But are you also looking at the incidences of NCDs such as diabetes and stroke? Because this is, I think, a very good area where you can get a lot of information, especially taken from the African continent. I think those are my only questions. Thank you.
Yeah. Working group 1, any representation from working group 1? Yeah. I think first question is for working group 1. Yeah.
Yeah, thank you. So I heard from Bhaskar, there's a quite good working group working well. The CRBS capacity building is highly required in the country, as he also states on that. There are, since we are doing in the partnership, we have lots of training resources developed by the World Bank. So I've also gone through the training, basic training for CRBS, advanced training for CRBS. That can be, those resources can be promoted in favor of the CRBS capacity building rather than developing another training package and other resources. So better to promote those resources. Just see the recommendation from myself. Thank you.
Yes, please.
Good morning, everyone. My name is Dr. Lucas Nyabero, and I am from Kenya. I have a couple questions that I would like to share to ask. First of all, there's a lot of data is normally monetized at a very high rate by especially the private sector, and we are collecting data. We're talking about how to collect data is there a plan to monetize? And if we monetize, are we going to be able to, how do we move some of those benefits to the patients who gave us those data? Because a lot of times we collect data from patients and then they don't benefit when we monetize that data. Is there a way, is there a thought process, is there a group that is thinking about how to monetize the data we collect? Number two, pharmacy is actually normally the first entry into healthcare and sometimes the last exit from healthcare. It looks like it's missing from most of the presentations. Data from pharmacy, which is normally a treasure trove and is probably a very good indicator for public health, seems to be missing in all the presentations. Yes, I heard about the lab, but pharmacy was missing, especially private sector pharmacy, where every mother whose child is having a headache, they will go there first before they see a doctor because of the access and the availability of the care that they kind of think they need. Last but not least, the CRVS. There's a lot of myths around it, and there's a lot of myths and conspiracy theories and everything else. And I think one of the things that we have to be very careful about is how do we prepare the public to understand that some of those things are myths, what are myths and what are true, and what the benefit is for having it and the benefits that it'll bring to the country, to them as people, so that we can have participation. Because if we don't have participation, then we can have all the meetings we want, and we will not get to where we need to get to. Thank you very much.
Yes.
Okay, thank you so much. Thank you for the wonderful presentation from the regional group. I have two questions to ask. And the first one is, I would like to know how can HDC support the new countries to be part of the regional platform or regional technical working groups? Because it's like the new countries actually need a lot of capacity to be able to do some of the tasks related to the data analysis and use. If I may take this example for the Gambia Health Management Information Program unit is a unit which actually need capacity. Looking at the data analysis and data use in the country is very low. It's not because people don't actually want to use the data, but the capacity gap actually limit people to use data. So we need actually capacity on that aspect. And the other one is for my neighboring country, Senegal. It's like they have a very good laboratory information system. So there also, I would like to know whether they have a separate system from the routine data, or it is that they have the laboratory information system incorporated in their routine data. Thank you.
Thank you. With the limited time, probably we need to limit the questions. And now there are a few questions asked from the audience, and the working group representative probably can answer some of these questions with regard to one is about the CRVS. There was a question on CRVS. Is there any?
Thank you very much. Let me respond to the question that came from her. CRVS is all encompassing, and we have like different ministries like Ministry of Health, Ministry of Planning, ministry where the civil registration authorities sit, and then also you have Prime Minister's Office, Ministry of Finance, National ID authorities. Unless all these players come together, it's going to be very difficult to have a shared understanding on the pathway for CRVS. Okay, so wherever we operate, like we try to bring all players together. This is what we did during the UNGA side event. Like 6 countries, they came up like you had CRVS guys, you have guys from Bureau of Statistics, you have guys from National ID authorities. And also in case of Pakistan, NADRA was there, like NADRA is the National Identity. Okay, and then somebody from the Child Rights Committee and also from Ministry of Finance. Like in Cameroon, there was a senior minister. So I completely agree, unless all players, like will come together, it's going to be difficult. Okay, and we're working on that direction. Responding to Pavan's question, like the World Bank course is a good resource, especially to explain the normative path. okay, like on CRBS. But what we need now is, like the operational aspect, so we need to have more short and precise and sharp modules, like to explain how things should be done on the ground. And perhaps that was the reason we came up with that e-learning course, okay, to explain how birth and death registration should be done, like especially in the health settings. Okay, we are also working on a couple of different aspects, but then I tell you, like it has to be a combo. Like it has to be a combo. The World Bank is in the process of revising the course material, and we have provided our feedback. So hopefully the next iteration will have some examples, some country examples. I think I have answered.
Thank you. Another question is about the in emergency, how the health information systems respond during this emergency period. So probably anyone from working group or WHO side, anyone from WHO?
You mind just repeating the question again? Thanks.
Yeah, I suppose it's from your someone asked about the in emergencies, how this health information system should respond.
Yeah, it's a good question. So around 2.5 years ago, the Health Data Collaborative, with the guidance of several partners, some of whom are in the room, but also some of the bilaterals, wanted a working group specifically on, I'm going to say humanitarian environments, but also it included emergencies as well. We tried to get that group up and running with support from internal support from WHO, but also support from CDC as well. Unfortunately, the working group, it came up with the terms of reference, and we understood there's a big demand for it. But for different reasons, the working group kind of folded. So I think from the Secretariat side, if there's a demand for a working group that's specifically looking at aspects of surveillance in emergencies and data management in emergencies, those are the two things in the terms of reference, be very open again to try and resurrect the working groups. But I would say with working groups, we have 7 just now in the HDC, and it does take a lot of management to facilitate all the working groups to work. But it's up to you. If you want to resurrect that working group on emergencies, we're very open to it. And I think there's a lot of appetite, certainly from colleagues in emergencies in WHO, from CDC, and there were 2 bilaterals specifically that were really pushing for it as well. Thanks.
Yes.
I'd just like to contribute to the answer and share the example from Ethiopia. So the health cluster, which is a whole organization within the country and responding to the emergencies and especially the humanitarian aspect. So all the NGOs, UN agencies that are involved in the emergency program, they come together under the health cluster. And this is actually led by the Global Health Cluster based in Geneva. So we have that oversight and that guidance. And they have come up with tools that help us monitor what each player in health in the country is actually doing. So we have dashboards, we have the maps, very, very well organized. So I think in the different countries, if there's this demand, look at what the Global Health Cluster is doing. And maybe that might actually not even necessitate us having to form another working group because it's already being done at that level. Thank you.
Thank you. There's one last question about the monetizing the data, about the patient's data and the pharmacy data. Working group on data, routine HIS, or community data groups?
I would say it's a very good question and very complex. I think the person who asked is from Kenya, and he knows that we have actually monetized some data. For example, when you use a software called eCitizen in Kenya, you are charged some money they call the convenience fee. And in their last meeting, we were wondering who should benefit from this convenience fee. So one person said the Ministry of Health is the one which produces data, so they should get maybe a percentage. Somebody said we are the ones who enter, we want some percentage. And then the developer of the software also said he has a percentage, but unfortunately we forgot the patient. So we didn't put how much you would get, but it's actually 50 bob convenience fee. Like if you like birth registration or some of these things we ask for. So there's some monetization. And also if you want to check, like there is a system where you can know your statistics, your names. If you put your national identity card, it will give you all the particulars. And there are some people who want to really verify whether it's you or not. So you pay some money on that. It's still data. So I like the idea of monetizing it. It's already started in Kenya, but we need really to think of the patient. And I think it's a very big research question on how we can monetize and maybe say thank you to the patient who gave us the baby that we are registering and people are benefiting from it. So I'll just leave it at that, that is complex. Thank you.
Yeah, probably that will be an interesting topic for the next 1 or 2 years for the HDC Secretariat to look at. So with that, yes, please.
Sorry, I just want to add to that. I think most of us are aware of the Hella case in the US, of the lady who gave us a lot of the cells that we use for ovarian cancer and other cancers. And the family now cannot afford healthcare because of what yet a lot of the big pharma really made billions of dollars from those cells. So what I'm suggesting is not necessarily even just the fee, but for example, the data that we use, I mean, the Framingham study, some of those people who participated there gave us aspirin and how we use aspirin for cardiovascular disease. Did they benefit in any way? And yet the whole world has benefited from their work. So it's how do we look for smart ways? Because if we can monetize that, then we don't need to, we can monetize some of the things that we do here. We can pay for making that data better and more useful and democratizing of that data. Thank you.
Thank you. With that, we conclude this session, and I would like to thank all the presenters for their valuable contribution to this session. Thank you.
I think we have a coffee break just now, which is lasts for 15 minutes. So thanks, everybody. Thank you.
Where most of our reports come in.
Data is very powerful and is very important into our district or into the national level.
We are able to understand and know how many of our clients need assistance. We're able to understand the burden in the district.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
It influences the partnerships, how they would help the district, how can they help at national level.
So in this here office, that's basically where most of our reports come in from various health facilities on a monthly basis. As the reports come in, we track which report has been brought. We check if the information within the report is correct, if the information within the report is completed.
This data comes as raw. When it is compiled now, it becomes a district report.
Once that is done, the ministry at the headquarters, the coordinators of those various programs are able to track and see the pattern or the numbers that we capture within the DHIS.
Part of what we do is, with this data, we do our reports. So that informs us of where we are, what we are doing. Are we meeting our targets? Are we still doing what we said we were going to be doing?
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients we have. This really helps us to make a case for provision of services, especially some of our clients are out in catchment areas. We are able to understand where to take our services to.
Without the facilitators collecting that data and reporting to us, we'll never have an idea of what is happening in the field. Then we are able to react based on the data reported. Hence, I'm saying what data is very important as far as decision making is concerned.
It helps in that when I refer a client to the next service provider, I already give that service provider information. So the client doesn't have to go there and repeat what they have said to me, and it saves them their dignity, and it gives them, kind of some power to say at least, and also to reassure them that we are interested not just in their story, but we are interested in giving them service that will help them go through what they are going through.
Data is very powerful and is very important into our district or into the national level.
We are able to understand and know how many of our clients need assistance. We're able to understand the burden in the district.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
It influences the partnerships, how they would help the district, how can they help at national level.
So in this here office, that's basically where most of our reports come in from various health facilities on a monthly basis. As the reports come in, we track which report has been brought. We check if the information within the report is correct, if the information within the report is completed.
This data comes as raw. When it is compiled now, it becomes a district report.
Once that is done, the ministry at the headquarters, the coordinators of those various programs are able to track and see the pattern or the numbers that we capture within the DHIS.
Part of what we do is, with this data, we do our reports. So that informs us of where we are, what we are doing. Are we meeting our targets? Are we still doing what we said we were going to be doing?
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients do we have. This really helps us to make a case for provision of services, especially some of our clients are out in catchment areas. We are able to understand where to take our services to.
Without the facilitators collecting that data and reporting to us, we'll never have an idea of what is happening in the field. Then we are able to react based on the data reported. Hence, I'm saying what data is very important as far as decision making is concerned.
It helps in that when I refer a client to the next service provider, I already give that service provider information. So the client doesn't have to go there and repeat what they have said to me, and it saves them their dignity, and it gives them, kind of some power to say at least, and also to reassure them that we are interested not just in their story, but we are interested in giving them service that will help them go through what they are going through.
Data is very powerful and it's very important into our district or into the national level.
We are able to understand and know how many of our clients need assistance. We're able to understand the burden in the district.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
It influences the partnerships, how they would help the district, how can they help at national level.
So in this here office, that's basically where most of our reports come in from various health facilities on a monthly basis. As the reports come in, we track which report has been brought.
Data is very powerful and it's very district or into the national level.
We are able to understand and know how many of our clients need assistance. We're able to understand the burden in the district.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
It influences the partnerships, how they would help the district, how can they help at national level.
So in this here office, that's basically where most of our reports come in from various health facilities on a monthly basis. As the reports come in, we track which report has been brought. We check if the information within the report is correct, if the information within the report is completed.
This data comes as raw. When it is compiled now, it becomes a district report.
Once that is done, the ministry at the headquarters, the coordinators of those various programs are able to track and see the pattern or the numbers that we capture within the DHIS.
Part of what we do is, with this data, we do our reports. So that informs us of where we are, what we are doing. Are we meeting our targets? Are we still doing what we said we were going to be doing?
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients do we have. This really helps us to make a case for provision of services, especially some of our clients are out in catchment areas. We are able to understand where to take our services to.
Without the facilities collecting that data and reporting to us, we'll never have an idea of what is happening in the field. Then we are able to react based on the data reported. Hence, I'm saying what data is very important as far as decision making is concerned.
It helps in that when I refer a client to the next service provider, I already give that service provider information. So the client doesn't have to go there and repeat what they have said to me, and it saves them their dignity, and it gives them, kind of some power to say at least, and also to reassure them that we are interested not just in their story, but we are interested in giving them service that will help them go through what they are going through.
Data is very powerful and is very important into our district or into the national level.
We are able to understand and know how many of our clients need assistance. We're able to understand the burden in the district.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
It influences the partnerships, how they would help the district, how can they help at national level.
So in this here office, that's basically where most of our reports come in from various health facilities on a monthly basis. As the reports come in, we track which report has been brought. We check if the information within the report is correct, if the information within the report is completed.
This data comes as raw. When it is compiled now, it becomes a district report.
Once that is done, the ministry at headquarters, the coordinators of those various programs are able to track and see the pattern or the numbers that we capture within the DHIS.
Part of what we do is, with this data, we do our reports. So that informs us of where we are, what we are doing, are we meeting our targets, are we still doing what we said we were going to be doing.
We collect this data every day, every week and every month. We analyze the data and then we ensure to know which kind of clients we have. This really helps us to make a case for provision of services, especially some of our clients are out in catchment areas. We are able to understand where to take our services to.
Without the facilities collecting that data and reporting to us, we'll never have an idea of what is happening in the field. Then we are able to react based on the data reported. Hence, I'm saying what data is very important as far as decision making is concerned.
It helps in that when I refer a client to the next service provider, I already give that service provider information. So the client doesn't have to go there and repeat what they have said to me, and it saves them their dignity, and it gives them, kind of some power to say at least, and also to reassure them that we are interested not just in their story, but we are interested in giving them service that will help them go through what they are going through.
Data is very powerful and is very important into our district or into the national level.
We are able to understand and know how many of our clients need assistance. We're able to understand the burden in the district.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
It influences the partnerships, how they would help the district, how can they help at national level.
So in this here office, that's basically where most of our reports come in from various health facilities on a monthly basis. As the reports come in, we track which report has been brought. We check if the information within the report is correct, if the information within the report is completed.
This data comes as raw. When it is compiled now, it becomes a district report.
Once that is done, the ministry at headquarters, the coordinators of those various programs are able to track and see the pattern or the numbers that we capture within the DHIS.
Part of what we do is, with this data, we do our reports. So that informs us of where we are, what we are doing. Are we meeting our targets? Are we still doing what we said we were going to be doing?
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients we have. This really helps us to make a case for provision of services, especially some of our clients are out in catchment areas. We are able to understand where to take our services to.
Without the facilitators collecting that data and reporting to us, we'll never have an idea of what is happening in the field. Then we are able to react based on the data reported. Hence, I'm saying what data is very important as far as decision making is concerned.
It helps in that when I refer a client to the next service provider, I already give that service provider information. So the client doesn't have to go there and repeat what they have said to me, and it saves them their dignity, and it gives them, kind of some power to say at least, and also to reassure them that we are interested not just in their story, but we are interested in giving them service that will help them go through what they are going through.
Data is very powerful and is very important into our district or into a national level.
We are able to understand and know how many of our clients need assistance. We're able to understand the burden in the district.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
It influences the partnerships, how they would help the district, how can they help at national level.
So in this here office, that's basically where most of our reports come in from various health facilities on a monthly basis. As the reports come in, we track which report has been brought. We check if the information within the report is correct, if the information within the report is completed.
This data comes as raw. When it is compiled now, it becomes a district report.
Once that is done, the ministry at the headquarters, the coordinators of those various programs are able to track and see the pattern or the numbers that we capture within the DHIS.
Part of what we do is, with this data, we do our reports. So that informs us of where we are, what we are doing. Are we meeting our targets? Are we still doing what we said we were going to be doing?
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients we have. This really helps us to make a case for provision of services, especially some of our clients are out in catchment areas. We are able to understand where to take our services to.
Without the facilitators collecting that data and reporting to us, we'll never have an idea of what is happening in the field. Then we are able to react based on the data reported. Hence, I'm saying what data is very important as far as decision making is concerned.
It helps in that when I refer a client to the next service provider, I already give that service provider information. So the client doesn't have to go there and repeat what they have said to me, and it saves them their dignity, and it gives them, kind of some power to say at least, and also to reassure them that we are interested not just in their story, but we are interested in giving them service that will help them go through what they are going through.
Data is very powerful and is very important into our district or into a national level.
We are able to understand and know how many of our clients need assistance. We're able to understand the burden and the district.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
It influences the partnerships, how they would.
Okay, so welcome back to the session on going over the evaluation and getting your inputs and thoughts on how to practically implement. Our colleague Isaac from Malawi has got called away to a work-related meeting, so unfortunately he's away for the next hour. So what I'd like to do is just call upon Sam Kanga and Bakari Barrow from Gambia. If you could kindly help facilitate the next session, Sam and Bakari, if you're around. Thank you. Thanks, Sam and Bakri. Over to you. One thing before we start around the working groups was we heard some fantastic presentations and feedback from some of the working groups, but not all. There are 2 working groups that are very active, including the GIS working group and the Data and Digital Governance working group as well. So those are 2 other technical assets, resources available for countries within the Health Data Collaborative, and they've been relatively active over the last 2 years. So just so that you know, there's 2 other working groups as well. So over to you, Sam and Bakri. Thank you.
Good morning, everyone. Good morning. I trust you had a good break. Welcome to session 5. Myself and Bakari will be facilitating, and it's focusing on moving the HDC evaluation recommendations forward. We shall focus on this for the next 2 hours, and we shall have a couple of presentations. And after each presentation, we'll have a question and answer session. And depending on time, we can see how many questions we'll allow at a time. So the aim of the session is to present the renewed HDC objectives and strategies in line with the HDC evaluation that concluded in September of 2023 for consideration and endorsement. And to take us through this will be the HDC Secretariat. And the first presentation will focus on the HDC objectives and scope. So I'll invite the first presenter, I believe it's Craig, to take us through that. Welcome.
Okay, so thank you. What we'd like to do on behalf of the Secretariat over the next while is to go over some of the recommendations that were made in the evaluation. But before doing that, let me explain a little bit about the reason why there is an HDC evaluation. As you know, the HDC was born in 2016, and we're at the midpoint of the SDGs. And obviously, we've just come out of the pandemic, and there was a lot of influences and positive suggestions we had about the direction of the HDC and what the HDC could do. So a lot of us around 2 years ago, we thought we really need an objective external evaluation that can really give us guidance. When I say us, I'm meaning us as a community of what do you want or need from the HDC moving forward from now, the midpoint of the SDGs, to 2030. So we drafted a TOR for an external evaluation to happen, and that was approved by the stakeholder representative group. And we put together, there were several bids for that, and a group called SIPA undertook the evaluation on behalf of the HDC. So what myself and Tashi and Isabella and Pandula are going to present next are the recommendations that were made from that evaluation. Next slide, please. And we think it's really good process to actually have an evaluation because it gives us a stronger footing from an objective point of view with some good recommendations. And as our ADG Samira told yesterday, it's good practice, it's best practice, and it gave us some really good positive and negative feedback, which we've taken action on. So just for your information, the evaluation started in March this year, but there's a lot of preparation over the last year and a half to do so. SIPA did that evaluation based on the OECD DAC recommendations for good practice of evaluation. They undertook a literature review of all the background documents of the HDC. They interviewed many different stakeholders. I think there were roughly 60 different stakeholders from the different constituencies, from countries, and from different groups in the HDC. They also undertook 6 specific in-depth country evaluations to see the pros, cons, impact or non-impact of the HDC as well, and then presented their conclusions at several times back to the SRG and to the Secretariat for fine-tuning their recommendations. So the recommendations are publicly available now on the website. If you look on the HDC website, they're all there. The background documents on all the recommendations are there. So as you can see from the timeline, really from August, there was a presentation to the SRG on the initial findings. The draft evaluation report was shared with the HDC on the 14th. And really since September until now, we've been working very hard on the Secretariat of looking at each of the 5 recommendations that you'll hear and how to practically implement them. So the discussion today, what we'd like from you is really some practical guidance on what you want to move forward with the HDC based on these 5 recommendations. We're not really going backwards like we don't agree with that conclusion or this conclusion. It's much more, let's work together as a community, as a team on practically moving forward on each of the 5 recommendations. So what we'd like to do today is really, we've got the finalization of the proposals. The Secretariat, many of us have been working hard on practically moving forward. I'm going to present these to you. So next slide. So the first recommendation was really all about the scope of the HDC and the aim and the objectives of the HDC. So based on the evaluation and feedback that we've had, we were tasked with revising the scope of work, the scope of the HDC and the objectives, the theory of change, a much clearer work plan linked to key partner and working group activities in the work plans, and an updated results-focused M&E framework with some very specific indicators that can measure the impact and progress of the HDC. And why we want to emphasize that is not only because it came out of the evaluation, but because it gives us much stronger power advocacy tool to go to donors, to go to others who may well want to support the HDC. The first question that we get asked is, what's the added value and how are you going to demonstrate your impact? So that's the reason why we really focused on the M&E framework. And the other recommendation that came out of it, and we'll talk about that this afternoon, is the investment case for the HDC and the working groups as well. Next slide. So what we're proposing now is that the aim of the HDC is to strengthen countries' health information systems. So that's number 1. Health information systems are the center of what the HDC does through effective collaboration. Secondly, so that word collaboration. And this is what we're trying to do in a meeting like this, to set up an informal way of collaborating where you actually collaborate with each other. And there's a sense of trust and a sense of community around data. And that's really what we're trying to build up. Enabling countries, that's the third point, really putting countries at the center of directing how partners and working groups direct the resources effectively to better monitor and attain the health-related SDGs. There is actually, with a focus on leaving no one behind and communities left behind, but we want to emphasize the focus is on the 2030 agenda and contributing to data-related efforts that push us in the direction of the 2030 goals. We're suggesting that there are 3 objectives. One is to support the development and dissemination of knowledge products aligning with country priorities. What do we mean by knowledge products? We're meaning tools that may be developed by different technical working groups. There may be knowledge products that might be capacity building efforts through regional institutes, through working groups, or through different agencies who are parts of the HDC. And the HDC is the platform to help share, disseminate, and sensitize some of those products. Second objective would be to support country-to-country, peer-to-peer engagement and learning. And that's one of the reasons why we hosting this meeting on behalf of the HDC to really pull together, and what we went through yesterday is peer-to-peer learning, so countries are able to learn from each other, critique each other, share good practices, and moving forward, perhaps not only through meetings, but through webinars and HDC hosted events to really strengthen that, ideally in the regions, not necessarily in the global north, but in the regions in Africa, in Asia, and perhaps other regions as well that we can talk about. And the third objective would be to enhance effectiveness and efficiency of health information systems through targeted advocacy and communication. And that relies a lot on our partner agencies who are part of the HDC, but also building on the event in May that many of you know about, Better Data for Better Health, which talked and made the case for better investing in health information systems. There was an investment case made, and you heard yesterday from the data dividend work, and better investing in data governance as well. So those are the three objectives that we're proposing for the HDC and the overall aim based on feedback that we've had from the evaluation and the work September until now. Next slide. What I think I'd like to do is just, we go through, what I'd like to do is just go through the whole of the recommendation 1, which includes the theory of change and the work plan, and we'll have feedback on recommendation 1. So I wonder whether, I think next one is Isabella on the theory of change. So do you want to talk us through the revised theory of change, Isabella? And we'll take all recommendation 1 together, and then we'll have Q&A and your feedback on recommendation 1. Thanks. Over to Isabella.
Thank you, Craig. Thank you, everyone, for listening. So Craig has let us know the recommendation 1 from the evaluation, and just a recap that we should have an updated theory of change that is comprehensive, but also responds to the updated scope. And we have seen the scope, the aim, and the 3 objectives. So based on that, we have, together with stakeholders, revised the theory of change, the HDC theory of change, focusing on 3 strategic objectives, strategic focus areas informed by the 3 objectives that we have seen. One of the focus areas is knowledge brokering, as we have heard from objective 1, capacity building, advocacy, and communication. And we are looking at all these, how we'll implement together to lead at the impact level improved use of data to achieve health-related SDGs for improved health outcomes. If you remember day 1 presentation, what HDC and why. So looking at this, for example, if you look at the knowledge brokering, just as an example, the issue is how at the input level, how do we leverage on country, regional, and global technical expertise to produce, disseminate, contextualize, and harmonize global public goods. And the working groups have told us about the global public goods that they are producing. At the output level would be production, sharing, and use of technical knowledge products for collective action. That would then is expected at the outcome level lead to optimal use of global public goods. And that is expected to lead to our final impact, improved use of data to achieve health-related SDGs. In terms of capacity building, the same focus, just maybe to take us through this, capacity building, providing a platform for facilitation of learning and peer-to-peer exchange. And I believe we did this, and this is what we are doing. We did this yesterday already. This is expected at the output level to lead to increased capacity to collect, store, analyze, and use data for decision-making, and then availability of quality data, and then leading to the impact. In terms of advocacy and communication, leading to enhanced awareness, increased rationalized investment in HIS, and so forth. And all of us working in HDC should then respond to this. And we are told that HDC works through the working groups. So how will the working groups then respond to this theory of change? So they would contribute directly to knowledge brokering. And if you listen to the RHIS, they had that as one of the key deliverables for the coming year. Then contribute to capacity building and also advocacy and communication. If we could go to the next slide, please. So based on that, again, with the stakeholders, the Secretariat with stakeholders have crafted a work plan based on the recommendations that we have seen and finalized in December. And as Craig has said, we are looking forward to discussing how then we implement this work plan together. How best do we mobilize resources for the entire HDC, but also resources for working groups, so that then this work plan is implemented. Again, the work plan is highly linked to the 3 objectives, highly linked to the 3 strategic focus areas of HDC. Just as an example, I won't read through the whole, the whole work plan, but if we look at the knowledge brokering, the activities would include publication of guidelines, gather country best practices. For example, that as we have gathered here, how then do we continue using the platforms that we have to gather best practices? Then partners mapping tool, and we'll be taken through this in a short while, maybe later on in the afternoon. Then opportunities for peer-to-peer learning, and we have seen that already. And then how to contextualize and support development of global data governance framework. Then at the output level, production sharing, and then outcome evidence-informed decision-making. What I'm trying to demonstrate is that this work plan is linked to what we have seen, the theory of change. If you take the activities that are being implemented under each of the strategic focus area, they are also contributing to the theory of change. The HDC working groups will also contribute to this. If you listen to the last bit where you are looking at the work plans for the working groups, then they are all responding to this. In terms of capacity building, having HDC hosted workshops, either virtual or in person, monthly webinars and so forth, leading to capacity building initiatives, increased capacity to collect and store data. I'm not going through the indicators because the next presentation will be on the MNE framework. But I wanted to highlight beyond the advocacy and communication, beyond the 3 strategic focus area, because as we learned yesterday, HDC has a secretariat hosted by WHO. So in the work plan, we also have the activities that will be implemented by the secretariat. One is monthly board meetings or frequency that may be determined, and we shall later listen and hear about the board. And then working group meetings. The secretariat does coordinate the working groups, the ones that we have had, so that we have a more effective secretariat, a better governance, functioning governance structure, and so forth. So this is what we have, and we are looking forward to an interactive discussion on how we take this work plan forward. How do we mobilize resources for the entire HDC, and also resources to be able to meet deliver the work plan, the working groups deliverables as presented earlier on in the day. Thank you very much, facilitator.
I think we're taking questions at the end for recommendation 1. So I'll be presenting on HDC's MNE framework. So the evaluation that was conducted this year and concluded in September said that the monitoring and evaluation framework that the HDC initially had is not clear enough. It's not results focused, and that we could do, improve on it, and that it's not really connected well with the activities that we had. So the Secretariat made a first attempt at improving the MNE framework, but we also had various opportunities to present. Firstly, we had a workshop which was open to everybody in the HDC and beyond to join us. I think many of you were able to join and also input. And we had 2 other occasions, that was to the SRG where we presented, and the comments and inputs were well received and incorporated. We also had several volunteers who reviewed this and were able to guide us. But I mean, there's still a lot of room for improvement. We could have these fancy strategies plans, but at the end of the day, it has to work, and it has to work for you, for us, for everybody. For instance, as you work with the communities, as you work with other partners in the countries, it has to work for you. And we really hope we can improve on this further. So my colleagues Isabella and also Craig pointed out our aims, our objectives, and our 3 strategic priorities, which is the knowledge brokering, capacity building, advocacy, and communication. So what we try to do is we try to be a bit more results oriented. And for instance, I don't think I will go through all the indicators one by one, but we have for the 3 strategic priorities, and supporting everything is the Secretariat, which was pointed out very well by Isabella. So we also added that as an output, because that is important to drive progress, results in all the other areas. And at the results level, we are proposing 2 indicators. We had several criteria that we considered while proposing this. Some of the criteria was that it should cover all aspects of HIS, because the HDC's scope is very broad and it covers a lot of HIS areas, and that it should not exert any reporting burden on the countries, and that we should make use of the already existing reporting mechanism, and that we should not have a lot of indicators, just 2 or 3 indicators at the max. So these were quite easy because it's already there in the SCORE report. That was published sometime in 2020 for the time period of 2013 to 18. Please correct me if I didn't mention it correctly. But and then at the outcome level, the indicator is number of countries with data available for at least 90% of indicators to monitor the health-related SDGs. The baseline in the report is 42 as of 2019. And we feel like it would be reasonable to at least hope to have more than 100 countries to achieve this. And at the impact level, percentage of countries having moderate or better capacity for each of the 5 SCORE interventions by 2030. So as you know, in the SCORE report, there are 5 interventions. So we really want to improve on the 5 interventions and at least help countries have moderate or better capacity for all these interventions. So this is our proposal. And we hope that we get input on this, especially on the at the higher results level. And I think this is it for my presentation, and hope to hear from everybody during the feedback and the question and answer session. Thank you.
Great. Thank you for those 3 presentations from Craig, Isabella, and colleagues. So we'll go into a session of Q&A. For any question related to the HDC objective and scope, the theory of change, or the M&E framework. Any questions? Sure, you can go.
I see that you use the score to monitor any progress or change, but the score results, I mean, the old score was done using data from 2016, 2017, and the new score round will use the data probably from 2021 and 2022. But in the long run, we don't know if the score is going to be renewed, so what's the risk of if the score is not continued, but you use it to monitor? The question is, you have to ensure that the score is a continued assessment that will be used for you to assess. So I think you need to have a backup in case there's no score at all, because score is also very well, score is a donor-led, activity which WHO is doing, but without the funding, I'm not sure we can continue the score either. So there will be other indicators available in WHO which could support that. I think you should also look for alternative data sources over.
Thank you. Maybe we can take another 2 questions before we have responses. Sure.
Thank you. My comment is on
on the activities related to knowledge brokering. When we're talking about the knowledge brokering, it's a two-way work between the knowledge producers and the decision makers. So clearly we have activities here related to the translation of knowledge from data to decision makers. But the other way, which helps a lot, is to understand the knowledge need, the information need of decision makers, and reflect that in our information systems. I think it would be helpful to highlight that in the activities for the knowledge brokering inputs, specifically because it will help us to avoid a knowledge overload on decision makers that can result in the paralysis of using that knowledge. Thank you.
Thank you. Any other question from the three presentations at the end?
Okay, thank you very much, and thank you for the presenter for sharing the scope and the objective of the Health Data Collaborative. My worries is about the implementation of HDC at the level of the country, because I'm trying to see how this can be implemented at the level of the country. And one point I see related at the level of the country is coordination, intersectoral coordination. That could be one of the points that HDC can help to work on. And I think that coordination and the ability to provide a platform for the main sector, which is involved in the routine health information, the health information system within the country, is a point that is very important to highlight. And we can discuss further on it. I didn't see it within the work plan, but I think it's very important to, because if we think about the beginning of the HDC, the aim of HDC at the beginning was to reduce fragmentation, and one tool or one way to reduce this fragmentation is to try to have a platform where the main stakeholders working on health information system can sit around the table and discuss. I think that is a point we can think about and try to elaborate. Thank you.
All right, probably you could have some responses on these questions, or we can take one last question and then we have some responses.
Yeah, thank you so much, facilitator, for the opportunity. I have two questions. One question is on the result framework for monitoring and evaluations. I think if you can project the result framework, there's one of the indicators I've seen. It's talking about the social media, social media reach, and I really wanted to understand how best can that indicator be monitored, because given that we have so many social media platforms talking about different issues, starting from health to other social problems, and the target there, the baseline there is 404 as of this year. And they are targeting to reach 5,000 each year, starting from 2024. Reporting period quarterly and the social media platform as the main of verification. So how feasible is that? I need more clarification on that so that we go forward. My second question is about the technical working group for HDC. At different country level, I'm sure there are several technical working groups that are existing, and they are discussing the health-related information system. In my country, we have two different technical working groups. There is Health Information System Technical Working Group, and we have M&E TWG. So I wanted to understand, can HDC be integrated into the existing technical working group and be part of that? Or should it be a separate technical working group with a different TOR, which are a little bit different from what we already have at our different country levels? And can the HDC, how feasible is it to be implemented at the subnational level? Because there are a lot of parameters to be looked at when we are talking of, implementing the technical working group or HDC. Thank you so much.
Thank you for those questions. So let's first go through a round of answering those, and time allowing, we can take a couple more. I think I'll invite Craig. You can take the first question on this call.
Sure, and thanks. And I turn to other colleagues in the Secretariat to give answers too, but I want to so Doris mentioned using score only as an indicator for, I think there were two indicators there. So point well taken, Doris. It depends on funding and whether score will be implemented again. I understand that score will be implemented at least one more time. We'll see. But I think there should be some backup indicators, and your suggestions of backup indicators, we can obviously work with WHO colleagues, but also others as well to look at alternative indicators that we measure progress on. But one of the reasons why we're very keen to promote and give access to score as a framework is because it helps bring together a lot of health information systems activities with a specific focus on results and using data for action, and that score may be seen as a paradigm or a way of looking at how ministries of finance or donors might want to think about investing in health information systems. So those are the reasons why we're trying to promote score, but the issues of indicators are well taken. I wonder whether I could just quickly answer some of the other questions as well, and again, turn to my other Secretariat colleagues. So the question about activities in knowledge brokering and avoiding information overload are really well taken. And I think that's a really consistent message we get, that sometimes there's too much information, and actually what the HDC should be doing is to help sift through information for key decision makers in countries. But we rely very heavily on the technical agencies to support that work in countries, and also the working groups to contextualize their tools or products to make sure that they're context and country specific where we can, so to avoid that information overload. And we also encourage countries or issues that people want to raise in working groups to use the HDC as a platform to host webinars where you may well want to communicate and make sure that you get your messages across to the right decision makers. In terms of the question, a really good question about implementation in countries, you'll hear in a bit the country engagement strategy, which has been revised. And we hope, if you have any comments on that, we really welcome other thoughts on the country engagement strategy. But the thing that came out with the evaluation, so you're right, when the HDC was first born in 2016, right at the heart of it is to decrease fragmentation and increase alignment of partner resources with country priorities. The feedback that the evaluation gave was that agenda is way too big for the HDC, and it's much broader, of course, than just data. So I think many of us feel that we can contribute to that agenda, but it shouldn't be the driving agenda of everything, because it's too broad. It requires very strong connections with health system planners, financiers, and others as well, which of course is broader than even the health system. So we contribute to that agenda, but it's not our complete raison d'etre as well. And that was fairly strong in one of the recommendations from the evaluation. And then lastly, the results framework, I think we take that on board with your issues of indicators. And if people have suggestions for different indicators, please send them into the Secretariat. And we definitely want to incorporate them as we move forward in the early part of next year. The issue of subnational implementation by HDC partners is well taken. And I think we'll need to kind of look at that on a country by country basis on where working groups sit. So the question from South Sudan on whether the HDC should, be a separate working group or separate. We really do not want that. We want to make sure that the HDC is seen as a mechanism by which partner support
supports and backs up and strengthens existing mechanisms in your country that are already working. We don't want to fragment further. So the HDC should be a way of aligning resources with your working groups that exist already. If there's a gap where you don't have a working group, then certainly I think the Secretariat and other partners can help you with working groups at national level if you want that. But maybe Isabella or Tashi have other thoughts on the questions. Thanks.
Thanks, Craig, and thanks everyone for the discussion. Nothing much to add, but just on the last one on coordination at the country level, just to emphasize what Craig has said, no need for duplication, and just refer us to what we learned yesterday from Uganda. They had a very nice lesson to share on how they made sure that the technical working groups, what they had in the sector, what they were proposing for HDC are talking to each other instead of creating parallel structures. Thank you very much.
I would just like to, sorry, Chair and facilitators, I'd like to take the floor to answer or add to two things that came up with regard to the monitoring and evaluation framework. On the first one, on the score assessment, I would only agree with what Doris said and with what Craig said as well. It is important that we have regular assessments so that we can update and periodically report on these indicators. But at the same time, it is also important to have or consider other indicators at the high results level, to have options up our sleeves. And this is where I want to request anyone, if you think that there are other appropriate indicators, to let us know. And on the second thing that colleague from South Sudan mentioned, he picked up one particular indicator on the social media reach. I just want to add that we have our colleague Carolina, who currently takes this role in the HDC Secretariat. I don't know if she has joined as of now and when previously. But when we say social media, it's basically the HDC social media handles, for example, HDC's LinkedIn, HDC's Twitter account. So we want to amplify our messaging on these platforms. And the baseline you correctly noted, 404, is the current following that we have. And the target 5,000, yes, it is ambitious, but we also feel like it is doable, and we only aspire to reach out to more people, but of course with your support. So that is all I want to say on the two things that came up. Thank you very much.
Okay, thank you so much. I guess all the questions have been answered correctly. So not to waste much time, we can proceed with the following presentations. We'll start with the governance structure. And this time around, after governance structure, there will be feedback and question and answer section. We can try to minimize the time as best as possible. Thank you.
Probably remove the video that is on the screen that covers the, yeah. Okay, thank you. So hello everyone again. So I'll present the recommendation for the governance structure. As you can see, it basically talks about simplifying what we have already, and I'll describe what we have already, and also to create a structure that is, small in terms of its number of members. And also we'll be having the mandate to give direction to the HDC as is move forward. And also a particular request is to include countries, civil society organizations in the and give it a voice within this structure in some form. And also for it to not to be political level, a body, but of course consisting of senior members from different organizations who can contribute to the decision making. And of course to the board to firstly to see how these new recommendations or the proposals are implemented in the early part of next year. Next slide, please. So the previous governance structure, if I may very briefly mention, consists of the global partners group, and it consists of 7 constituencies, as you may know. representing multilateral organizations, philanthropies, global health initiatives, academia, networks, and so on. So our previous structure, which is the stakeholder representative group, had representatives from each of these constituencies as well as from the working group. So the numbers were significantly more. The proposed structure aligned with the evaluation recommendations and have been now discussed at different fora consists of probably around 8 members. One probably will be from the host in the sense it may be that at the moment the WHO hosts the Health Data Collaborative, but in the future it might change. So that host organization might have 1 member in the board to facilitate the operationalization of the decisions. And then, of course, representation will be from all 3 levels, the global, regional, and national level. So that's why we have 2 representatives from global level, 2 from regional level, and 2 from a country level. And also we have a collective representation of the working groups in the board structure. So the key changes we could attribute to the name change from SRG to a board, a governance board. The number of members will be reduced, as you can see. And of course, we have also proposed to have co-options. Co-options facilitate additional expertise to be brought on depending on the need to advise the board. Of course, the 3-level representation and the difference in terms of how constituencies and the working groups are represented, as well as the meeting frequency, which we have at the moment, a monthly SRG meeting, which may be probably a quarterly meeting as we move forward. Then the mandates, as you can see, as what we have discussed earlier with regard to the objectives and the aims of the HDC. Firstly, to provide oversight in terms of strategic direction, and of course to review and approve HDC's work plans and the budget, and at the same time assess progress and whether there is a need to course correct as we move forward. And of course, to identify the risks that might hamper achieving the HDC's objective, and lastly, the strategic allocation of resources. So this is what we have proposed, not only from the Secretariat, but with the inputs from the stakeholders at different fora. And this is what we have ultimately have come up with. I think next slide is referring to the feedback, the discussion. Right, so thank you. That's an overview of the governance structure. It's open for discussion.
All right, thank you so much for the wonderful presentation. If you have any question, any feedback regarding to this presentation, you can raise it up.
I don't know whether, Craig, you have anything to add to that.
Okay, so if there is no question or feedback, then we can proceed to the next presentation, which is country engagement strategy.
Can I just add one thing? So just
okay, you have one question.
No, just for the board. So we'll be looking for nominations for the board in the coming months. And again, we value your advice on the process to do so, but we'll be asking for nominations from country level, from regional level, and from global level, and from one of the working groups in the coming month, and hope that you're excited and possibly put your names forward, or if you know colleagues in your groups, please do so. But you'll get a more formal email in the coming month. Thanks.
All right, thank you.
A question here too. Sorry. Yeah.
All right, okay.
Could we flip back to the slide that had the proposed structure of the board? I may have a question there. Yeah, right there. Okay. I'd wanted to check whether there's representation by any of the participating countries, but yes, I see there too there. Thank you. Okay, no question.
All right, thank you. Then we can proceed.
So thanks once again. So we have seen 2 recommendations. We are now on 3. There are 5 of them. So recommendation 3 is on country engagement. And the recommendation was improve engagement with countries by developing a country engagement strategy that is well communicated, understood, and does not focus on pre-selected list of countries. So move away from pre-selected list of HDC countries. So instead of talking of these are the HDC countries, we get broader and expose HDC to everyone. Then have a bottom-up, demand-driven approach to HDC work on HIS to strengthen country engagement, reorient events and meetings to ensure maximum utility for countries, including through south to south sharing of experiences. And I believe this is what has happened in this meeting as a start. Then HDC country strategy should be clearly communicated to partners and countries. So the next slide will focus on the proposals from the HDC stakeholders together with the Secretariat. Next slide, please. Okay, so as we wait and try to understand where countries are, we are proposing that the Secretariat, the regional institutes, the regional platforms who include the regional offices, for example, WHO office, UNICEF regional offices, UNFPA, the regional platforms that are here present, academia and the rest, we continue doing a situation analysis. Who is doing what, where, and when related to partner engagement in health information system. And we have a HIS, a partner mapping tool that will be presented later. So we keep updating that partners mapping tool to be able to understand the status in different, in different countries. And I believe that is what a colleague raised when they talked about the activities in knowledge brokering. Then create country demand. The fact that now we are not concentrating on just a few countries, then we create demand for HDC. How can we communicate better on HDC? And I believe this also came up yesterday in plenary. What is the value add for HDC, even for the countries that are not here? Okay, general awareness creation, and we have various modalities of doing that, webinars and so forth. And then because countries are at the core of HDC, the fact that we are supposed to have bottom-up approach, then countries then would be required to express interest. And this is very critical for sustainability of the HDC activities or implementation at the country level, because it's the country that is requesting and demanding then to be engaged in HDC. Once this is received, and yesterday we discussed that it can be received through the existing offices, for example, WHO, UNFPA, UNICEF, through the Secretariat, and then backwards. Then we have an in-country engagement. What is the HDC's role in fulfilling country HIS priorities? So here we'll identify HIS priorities like we've been doing with the countries. For those that are here, we know that we have had engagements after expression of interest to look at what are the priorities, basically what you are presenting yesterday. What are the resource needs? Who are the key partners in the country? And I believe the partners mapping tool, as we continue updating it, will show this. What can they bring on board? So that after expression of interest in each country, you would want to bring your stakeholders together so that you look at your priorities and what they can then support in. Then you have partners consultation at the country level. How can partners' resources be mobilized to fulfill the country HIS needs based on country-own plans? Yeah, because remember, HDC is not implementing any other activities outside the country plans. So it's really bringing together the in-country partners, looking at the country work plans and then implementing together. So what are the country needs verified by the stakeholders, then looking at opportunities for implementing that, identify key partners, then define the supporting frameworks and the timelines and indicators at the country level for success. Then resource mobilize so that you ensure that all the work plans for the different stakeholders who are implementing HIS in the country are then aligned to the government or to the country overall plan. And then a continuous monitoring and evaluation. Although this is stepwise, think of it as a cyclic process, because the MNE is actually informing the situation analysis. The situation analysis is informing the expression of interest and so forth, you know, the priorities and so forth. So monitoring and evaluation, sharing the best practices from the different countries, looking at HIS needs from the countries, documenting through the different platforms, again, the regional institutes, the regional consultants, and any other platform through which then you can then document. If you look at this area here, the working groups, partners, countries, indeed all stakeholders then have a role to support the countries. So this is the proposed country engagement strategy. A bit of it also will be presented later in the afternoon on the partners mapping tool and how we can use that to look at who is doing what where and better identify our HIS needs. Thank you very much, Chair.
Okay, thank you so much, Isabella, for the wonderful presentation. Back to the floor again. If you have any questions or feedback regarding to this presentation, you can kindly raise it up. Oh, okay, you can start.
Question of clarity. For instance, are you planning to write to all the WRs and tell them about HDC and for them to then start engaging with government on the value add for HDC? Is that one of the proposals on how to take this forward?
All right, next question, please.
Thank you so much for the presentation, Doc. I think I have, having seen now the whole picture of what we are measuring in terms of the indicators we're measuring for HDC as captured in the framework, and the picture on how the cascade happens within the countries where the implementation is done. I think one, there is a need for us to have a couple of indicators that are measuring country engagement. I think from your presentation, I see that the approach that we have taken is to measure activities, where I think I've only seen on partner coordination having activities being monitored, but what about the other things? And then in terms of implementation at country level, because we are talking about bottom up, what are some of the key common measurable aspects of our interventions within the country that are HDC related that we need to prioritize as countries? I think there needs to be that in the framework as well. And then because we are also changing the approach and saying that now we are opening it up to other countries, we're not pre-selecting countries. What does that mean for the presentations that used to be there before? Are we including other regions as well, or is it just specific to the Afro region, for instance, because that has been the implementation in the past? I think perhaps we could take the approach of regions, and then before we used to pre-select countries, but then we could also take the approach of regions so that we can learn from other regions that are doing better. And this is a good platform for us to implement that. Thank you.
All right, thank you.
Thank you for that presentation. I may have missed this, but is there a specific timeline that we are working with when it comes to establishment and implementation of the work plan and the strategies? And also, how do you ensure that there's proper composition when it comes to the technical working groups in country? I know you've shared the M&D framework, but how do you ensure that there's actually proper composition and adequate representation, especially for CSOs? Thank you.
All right, thank you so much. Can we have the response for these three questions?
Let me start from behind. Sorry for that. My understanding is that you're asking how do we ensure proper composition at the country level? Okay, so at the country level really depends on the country structures, but as discussed yesterday and as recommended by stakeholders yesterday, is that we should be as inclusive as possible so that we are including all stakeholders in our coordination structures who are then supporting us in HIS. Remember yesterday there was a discussion of civil society engagement, engaging other government agencies, ministries, for example, the Bureau of Statistics, foreign affairs, private sector, and so forth. If Manya was here, he would give you example like, let me wear the hat of Kenya. Oh, you're here. Okay, let me help you wear the hat of Kenya just to say, for example, in Kenya, you have a health NGOs network that is civil society, you have the private sector network, you have partners for health, but occasionally they all come together and also discuss HIS issues. So that's what I would say. And then going back, so are we including other regions? The answer is yes. So move away from pre-selected countries. In this meeting, we already have Africa and Asia as an example. So engage as wide as possible, because the idea is to engage and improve our HIS status for better health outcomes, focusing on SDGs that all of us are implementing. What are the key measurable priorities that HDC would then provide at the country level? I would then go back and say, really, it depends on the country plans. What are the priorities? If you look at all these posters, they sort of have priorities that are cross-cutting, like CRVS, but others are very specific to specific countries. So as long as it's HIS related, as long as it's a priority for the government in each of the countries, as long as the stakeholders, if you could go back to the slide on the country engagement strategy, as long as the stakeholders in the country level, as long as in the consultation, you're agreeing that this is what the country needs to implement, these are the priorities in the country work plan, and all of us as stakeholders at the country level then are aligned to those priorities. We are together, and then you can link then to the different HDC technical working groups, depending on the priorities where you would want, for example, using the tools that the technical working groups are developing. How do we measure the country engagement? If you remember yesterday, we had a presentation from Tashi showing the number of countries and the spread across. So we are still monitoring that. As countries monitor what is happening internally on HDC, on the processes, on the delivering of priorities and so forth, at that level, you're also looking at how many countries do we have. And yesterday we said that at the beginning of this year, we moved from 8 to the current around 20-something countries in both Asia and Africa region. Need to have a couple of indicators measuring country engagement. That's one of them. So WR, Rose, Ethiopia, you have asked whether writing to all the country offices would then help as a way of communication. I would say yes, it's a good recommendation. Letting the offices and actually regional agencies, WHO, UNICEF, regional platforms, let's communicate. And even after we go back to our country, let's give feedback. In any organization or in any meeting that you have, just talk HDC as a way of communicating. Other modalities are through webinars. For example, in Africa, we had one sometime in June, where after that, actually, we had a lot of expression of interest from the countries. So let's use different modalities of creating demand. Thank you.
Great, thank you. Thank you for the responses and also for the questions. With that, we'll move over to the next presentation, focusing on enhancing the effectiveness of working groups.
Thanks, Jeff, for inviting. So I'll take you through the recommendation 4. It looks at the working groups, which is probably the cogwheels of the HDC's engine. And it focuses on enhancing its effectiveness, the good work that's already being carried out, working groups, how to make it, more impactful, and of course, with a very focused approach towards countries and country needs. So some of the suggestions were about annual plans for the working groups, which we are in the process of formulating. with the working group. Some have already done so. We saw some of the deliverables already in the screen. And of course, supporting country engagement through working groups, connection and collaboration between working groups through annual work plans, because we see that there's working groups engage in sometimes similar activities within same countries sometimes. So there's a lot of learning and exchange that can happen within working groups as well. And of course, the SDG Secretariat will continue to support the working groups. And of course, another one is about resourcing. Can we move to the next slide, please? So we looked at two key areas that came through the evaluation, which is aligning with country needs and resourcing work group activities. So these are some of the recommendations that came through. Firstly, the working groups to be proactive in terms of engaging with countries through expressions of interest. And as you saw, when Isabel presented the country engagement strategy, at some point there were expressions of interest the countries make. It may be through various channels that they get to know about HDC, its value add, and its contribution potentially for enhancing HIS and data systems. So once these interests come through, then the working groups will proactively get engaged with the countries. So the direct, linkage between working groups and countries could be made. And of course, Isabel also mentioned about the partner mapping tool. We can park that for now because there will be a demonstration about the partner mapping tool later on. And that will be a tool that engages the working groups as well, because that's intelligence that the working groups can work with in addition to other partners. And then we have partner updates. We are proposing for those to be more regular and more robust within the working groups. So everyone gets to know what the other partners do and where the collaborations or the opportunities and sometimes low-hanging fruits may exist in terms of making country impact. Country representation at the working groups. We are trying to do that gradually so that the countries will be represented within working groups. They can share their learnings. They can also contribute to the existing work, the activities, as well as also become a voice for their needs. And they can take, and they will be heard better within working groups because all the partners are there. And of course, the cross-work group collaborations that we also want to promote. It's not that it's not happening, but it's to be more formalized. Then in terms of resourcing, we see different ways of doing that, budgeted through the annual work plans of the HDC. That's why we have the deliverables plan for the next 2 years and how that can be incorporated into the annual work plan and the budgeting of the HDC together. And then, of course, direct partner supported activities. There may be instances where the partners would want certain things to done. And for example, the digital health and interoperability working group, how they contribute to various production of various tools and engaging with countries is through such support. And then, of course, solicited resources, whether the working groups can themselves seek resources, funding through proposal development. And that's another approach that we can propose. And of course, to leverage existing resources, because countries, the regions already have some resources directed at various HIS data system areas, so that working groups need to build awareness about these and then probably channel their expertise through these so that they can support these activities. So these are some of the proposals that came through and discussed, modified during the past few months. And I think that finishes the update for working groups. Happy to answer any questions, if any.
Thank you, Bandula. Questions on the presentation from the floor? Yes, Craig.
Yeah. I just want to supplement what Pandula just said. So two things. One is sometimes from the Secretariat side, we're trying to stimulate good communities of practice. So there's a subject matter like RHIS or GIS that brings together people or experts or countries that are interested in that area. And that for us is not necessarily a working group, but a community of practice. It's slightly different. And this is where I think people get confused. The working group in the HDC is specifically what we're trying to do is build on the community of practice, but have a very focused deliverable or something that can be produced by the working group, ideally that is useful for countries in a time-bound manner. And that makes it easier for us in the Secretariat to lobby for resources and make things a bit more effective. So that was the first point, this balance between a working group that's really working on producing something as opposed to a community of practice. And we want to stimulate both. So we welcome ideas on how to do that. I think the second thing with the working groups is the communication between the working groups has always been a challenge because you're in specific technical areas. We've tried to do that on a monthly basis, but we welcome suggestions as well on how to strengthen the communication between the working groups so we have more of an overview and can support you in what you do with the working groups. It's just two thoughts. Thank you.
Thank you, Craig. Any other questions or comments? Yes.
Okay, so I co-chair with Bhaskar and Debra on the CRBS working group. I must say it is a responsibility, but the co-chair really put some thinking and ensuring that the groups meet every month. Sometimes it's not an easy task because we all have a lot of responsibilities, you know, but we ensure that at least one of us is always co-chairing at least once a month, the working group. So, and you always need to share information among what's happening, you know, in each country so that we are all transparent. What I'm trying to say is that it's sometimes not easy because you're overwhelmed with so much work on your side and trying to stimulate a group, you know. We have sometimes, depending on the timing, 20 people can turn up, and sometimes it's only 3 persons, and sometimes 2, or even myself, you know, I mean, rarely, but it's always a co-chair there. So you can get demotivated very quickly. You can, and that's the thing that we always try to bring something interesting in the monthly discussion, like demonstration of it. For example, we had the inequality assessment tour on registration. We had a donor coming to explain the work, you know. That then keeps the momentum going. It's very easy just to drop the ball quickly, and that's a risk. And I know you had 8 working groups officially, and you only presented 4 here. And what happened to the other 4, you know? But that's just also something to look at what has been functioning well, what hasn't been functioning well, that need to be remedied, you know, before we sort of starting to change rapidly the way it's working. Or I know it's never easy to keep a working group very active. I mean, we have chance to have Debra Jackson is very enthusiastic, you know, and Bhaskar is always on the field and having good ideas. And I'm trying to maintain the admin part of it with the working group, you know, responsibility. So we share the responsibility equally, and that's a balance. But that's what I'm trying to say. It's not easy. So it's something you as a secretariat should try to monitor each working group, those working well and those who are like fluctuating or trying to disappear, you know, and that's a responsibility of the secretariat, I think.
Yeah. Thanks, Doris, for those suggestions.
Can I just supplement? Sure. You know, something that will really keep your working group alive and kicking is more and more country implementation case studies. Okay. You know, because we are already in 2023, you know, like next year. So only 6 years left. You are already in the decade of action, you know, like if you go by the 2030 agenda. So a lot more emphasis would be on country implementation, because if you play around too much on the normative framework side, I think slowly and gradually, you know, like countries will lose interest. So we need to shift from the normative to the operational aspect, and that is something that will really help. Thanks.
Okay, thank you for the additional thoughts and comments. Any last comments or question? Thank you. Thank you, Bandula, for the presentation. We'll move over to the last presentation in this session, and that's on advocacy and communication mechanisms.
Hi, everyone. This is Carolina. So good morning or good afternoon to those online and in person. Bonjour aux collègues francophones. Désolée, mais je dois faire cette présentation en anglais cette fois-ci, mais j'espère que la traduction soit disponible. So I'll be talking to you very quickly about the recommendation number 5, which pertains, as the colleague presented, about communications and advocacy. And the focus of the recommendation was to ensure streamlined communications coming from the HDC and that are tailored to its specific audience. Next slide, please. I always say that the communications aspect of the HDC is more of a collateral of everything else that we do in the collaborative rather than something that stands alone. It's not a standalone activity, and it cannot be. It must reflect and it must amplify and it must share what we achieve as working groups, what we achieve as a community of practice, as Craig was mentioning, and what we achieve in terms of our knowledge brokering role and our capacity to coordinate across different environments. So we had some specific recommendations, and this is just a summary of the actions that have been taken, but also things that would be good to pinpoint at this meeting when we talk about the challenges in implementing this and taking it further. So I would just go briefly through this. You all have access to these materials in the background documents, but I would love to hear your thoughts on what are the current challenges and how we can move this forward. So one of the recommendations, the specific recommendations, was to map out different types of information and communication needs based on the audience, and then think of strategies on how to best reach them. We have laid this groundwork. It's the content advocacy strategy. It's available for everyone in the HDC. It's in the website, but it needs implementation. And our biggest challenge for implementation is really the engagement from other communication focal points in the HDC. So we have a list of partners who proposed or who suggested names from their own organizations, but we haven't been getting responses or activation from that group. So we'd love to hear from you. What strategies, what has worked in your experience, how to engage other communication actors beyond the Secretariat? Because, and I thank you for the colleague who asked about the social media monitoring, and I think Tashi tackled the question very well. But we have a social media presence through YouTube, LinkedIn, and Twitter accounts. But if this HDC Secretariat publishes, a few tweets and posts, but these are not amplified or reshared across the network, even though we want to have targeted communications, it's not going to reach who it needs to get to. So there is an effort, collective effort to be done, and we are collaborative, so we cannot run away from acting collaboratively. There is a need for collective action when it comes to media specifically. Right. The other specific recommendation was about how the HDC meetings should be managed and how the communication should be done regarding following up action points, and the specific added value for participants in those meetings. And we understand that this is a bit more of a admin/secretariat recommendation than a recommendation on the comms and advocacy strategy itself, because it pertains to the internal communications, let's call it that way, for the collaborative. So this will be, and this is again something that will come from the board or the renewed board structure, to also understand how that mechanism is going to function and how that communication can function strategically from the board to HDC membership more broadly, and vice versa. The third specific recommendation was to improve the website utility to country stakeholders. And this is something that we have taken very seriously. The website was revamped in 2022. This is wrong in the slide. It was revamped in 2022 and then continued to be revamped in 2023. Mwenya, who's in this room with you, undertook a huge effort to put together what we call the Knowledge Hub, cataloging hundreds of documents. But we do understand, and it cannot be a one-person job. Mwenya did a fantastic job getting this up and running, but we understand that we need to keep on fine-tuning this. And we are going to do this. This is part of our work plan for communications for next year. We have a communication strategy that is designed for the HDC audience, but that it needs focus on the big public. And this is something that we have been really trying to do more and more with the Twitter, with the LinkedIn. And also thank you to all those who volunteered to feature in short videos. So, you know, all of you who agreed to be recorded in a short statement, that will really help us to communicate to a broader public than just us. As Isabella was mentioning just now, it's not just not just us who are in this room. Also, this conversation could and should be taken to other colleagues outside the HDC, and to the big public in general. And then last but not least, partners are invited to amplify events via the HDC channel. But as I've mentioned before, we have low responsiveness regarding this. So how can we explore this collaboration with key HDC partners? We really value your ideas about this, your experience in your own organizations, and please do let us know how do you think we can reinforce the HDC role to amplify events, and else, you know, any other thing that is happening in the broader HDC network. Because as Deborah, the co-chair from CRVS working group, loves to say, the HDC doesn't exist in itself. The HDC, it's its partners. So we only exist so long as we communicate, as we make ourselves present. So over to feedback and any questions you'd like to take. But this is an overview of the recommendation pertaining to communications and advocacy. And we really value your ideas on this domain. Thank you. Over to you, Chair.
Okay, thank you so much, Carola, for the wonderful presentation. We'll once again welcome the feedback or questions and answers for Carola. So any question for Carola, please? Okay, we can take the first one.
Thank you very much. So within the HDC, do you have a dedicated communications unit or a communications person, whereby we can send articles or send things that we're doing in the country to you, so that it's centralized by yourself? I mean, as countries, we also have our own social media platforms, and we also do quite a lot of posting there. So that's a separate avenue to be used. But centrally, what's available? Thank you.
Okay, thank you. Any other question, please? If there is any other question, then Carola, could you please proceed to answer this question?
Absolutely. Thank you very much, Chair, and thank you for the question. So the short answer is yes, we do have a focal point, and for the moment, that's me. And I'm sorry for that, but you can send any materials that you'd like to see amplified to the HDC Secretariat in general, to the group, which is me, Craig, Tashi, Pandul, and Isabella at the moment. We have a monthly newsletter, and everyone in the mailing list in the HDC should be receiving it. And we have different sections in the newsletter, and one of them is really to get others to know what is happening across the HDC network. So if you have any articles, blog posts, anything that you would like to reshare or amplify, please do send it our way. It's HDC Secretariat at who.int is the same secretariat email that is featured in every communication and every email or brochure we have out there. And the other aspect of communication, which we'll touch a bit further down the road today, is the HDC webinars. I believe you've discussed this at some point during yesterday or today, but you can also make use of the knowledge brokering role of the HDC via the webinars. They're 1.5 hour monthly sessions to either present a tool or a topic, or to get feedback on the product you're developing. We'll talk further about the webinars a bit later, but it is another way of reaching out to the HDC audience. So you can feel free, all of you, please feel free just to drop us an email just with any request. So please reshare this If it's a social media post that you would like us to amplify, if it's an article you'd like us to send in an email in our next communication, or even if it's something that you'd like to present in the forum of the webinar. Thank you.
Thank you, Carolina, for that response. Oh, there's one more question at the back.
Yeah, maybe this one is more of a contribution to what she just submitted. And what I do think could be more proactive is to liaise with the communication focal points, both at the country level, country offices level, and with the ministry. Because I believe in every WHO country office, there's a communication focal point. Also, at the ministry level, they might also have a communication focal point. And there are regular information products that are being published at given intervals. So if there could be that linkage between the HDC as well as the communication focal point, then sharing of information could be more effective rather than, country offices or let's say focal point for the HDC to be sending out information. So if there could be that link between the communication focal point and Caroline, we could see more information products being shared. Thank you.
Thank you for the additional thoughts. Any last thoughts on Carolina's presentation? If not, we have a question. I think this is for Pandula from the online team. George Bevy asks, can a community of practice be established as a way of enhancing effectiveness of the working groups?
I think thank you for that question, George. And I think this is something that we as a team, as well as some of the other stakeholders have also brought up. And as Craig explained, working groups might not fit that particular role, given its structure and the need and how it has been established. But definitely there is a need for a community of practice, because we know that many of the networks that are thriving are communities of practice in a way. They have ways of sharing what they know, what they want to any issues that they want to resolve. HISP is one, Global Digital Health Network, another. I know there are many more. So that's definitely in the pipeline, but as the Secretariat or as with the other stakeholders, we haven't had that discussion in terms of what's the best way of doing that. Maybe platforms, and I value everyone's suggestions. If you are aware and if you have experience in setting up such communities of practice, I invite all our stakeholders to be part of that process. Yeah, thank you.
Great, thank you for that response. So that brings us to the end of session 5. And unless there are any last comments or questions, I'll hand it over to the chair from here. Thank you everyone for your participation.
Thank you, colleagues, for the wonderful discussion that we've had. We still have some time to lunch because we managed to discuss in a shorter period of time. So I will allow this time for a discussion, reflections on yesterday's poster presentations. Yeah, in case there could be some areas that we needed to comment on, but we couldn't yesterday because we were running short of time. I will allow this time between now and lunch hour for such kind of comments, reflections, discussion, and then we'll break for lunch. Anyone who'd like to make a comment from yesterday? Yes, Craig.
So it's a comment to all our country colleagues on the posters. One of the there are lots of recurring themes, but two ones that we noticed in the Secretariat was CRBS, but also capacity building. So it'd be really useful to hear from country colleagues. When you say there are gaps in capacity building, that's a huge area.
we're wondering precisely, do you mean pre-service training or in-service training or both? Do you mean in-person training with a formal style of training that's in person in a lecture hall delivered by an institute, one of your national institutes or regional institute, or do you mean online modules or both? And then in the terms of the technical areas, we're also in the Secretariat thinking about what area of capacity building is a priority for you. Is it data collection, storage, sharing, analysis, or use, for example? To give us some hints on what your priorities are in terms of capacity building would be really useful for our work plan. Thank you.
Thank you. Any of the countries would like to comment on that? While we are still reflecting on that, maybe we could have another comment from any one of us. Yes.
Yes, I have a general thought to HDC. It is what is the place of research data in the HDC's effort to strengthen health data for better decision making? I think that data and knowledge from health research could be as useful as routine data in informing decision making. I don't feel that this source of information is taken into account in the HDC's strategy and mission. And I recognize that research data are generally translated into knowledge disseminated through scientific publication, which are not necessarily accessible to policymakers. So, and I know that WHO believe that research results can be translated into like policy briefs to be available for decision makers. Thank you.
Thank you. Yes, we have a comment.
So capacity building, there are two aspects. One, like Craig is saying about the general capacity building training models or sometimes kind of course, and other is the specific, like I said, one example. In Sri Lanka, all the information managers, they are trained in the health informatics. So in other countries, generally statisticians, they go into the job but don't have the knowledge on the health and the IT. So there are different models available like public health informatics. We can capacitate national academic institution for running the course on public health informatics, so that people who are entering into the health system, they will be preoccupied with the knowledge of all the blended knowledge of the health, IT, and the database. So this can be one of the approach to promote the course of public health analytics and also the informatics. Another being specific, like ministry asked me to support for the ESR, some guidance on ESR. I looked into the document and found in 2006, WHO had produced one of the ESR manual for the country, but that is quite outdated due to the advancement in the technology. So this kind of resources can be updated to support the countries. Like yesterday, we saw there is big appetite for the ESR in the country. So we can provide such document updating what WHO and partners had in before. We can make update on that and provide to the country. That will be a good opportunity for the capacity building. Thank you.
Thank you. Beautiful insights still coming in. Any other comment?
Thank you. Yesterday, one common thread among many of the poster presentations was the issues of using unique IDs, specifically unique IDs that can be used across nations and can cover everyone, including non-citizens, non-residents, and those people who do not have maybe access to registration. I think it would be helpful to hear if we have any progress, any comments on implementing a unique ID that goes across programs in the HDC countries.
Thank you. Any country that can, yes, we have two hands on this step. Let's start with WHO and then go to Ethiopia.
Okay, thank you very much. I think concerning the capacity building, one area which we can focus on is use of data to inform decision making. And for example, in Cameroon, one point I think we are working on is it is a demand of the Ministry of Health is in order to strengthen their capacity to elaborate knowledge project, like fact sheet, like policy brief, to show that data can be used, because there is a lot of data which is collected. But what political leaders need is some information to take decision. And in my opinion, it can be an area to stress on, but on the subject related to the HDC objective. Thank you.
Thank you. Ethiopia.
Thank you very much, Chair. Regarding the capacity building related needs in Ethiopia, both in service plus pre-service capacity building activities needs focus. Just to give example, because the implementation is very low, as you see from the poster presentation. On medical certification of cause of death and ICD-11 implementation, one of the critical challenges is that of the awareness or the knowledge of medical practitioners, because these things were not embedded in their regular medical classes. So the country is trying to provide in-service trainings, but for long-term and sustainable impact, it has to be embedded in the pre-service training curriculum of medical schools for medical practitioners, health officers, nurses, and the likes. The other comment or point what I would like to raise for this platform is that I didn't hear anything about cross-border data sharing between countries. So is there any team or working group who can support that? Because in Ethiopia, we are trying to share data between neighboring countries for continuum of care, because there are people who are moving from one area to another seasonally. So there are activities or healthcare programs which needs to be continued. Thank you.
Thank you. I would like us to focus on these two comments. The first on the any HDC country that is using a unique identifier, and also on any HDC country that can share on the cross-border data sharing. Any insights on this? Anyone who can? Yes.
So in terms of using UIDs, unique IDs, during birth registration, this is happening across countries, including HDC's countries. Like Bangladesh has recently, like a couple of years ago, they started doing it. And which is a good practice, because in the process, you are able to establish an organic relationship with the national ID system. Okay. But then there are some pitfalls also. If the plan is to issue unique ID numbers in real time, and if your connectivity and logistical challenges have not been sorted out, then this will become a bottleneck. Let me give you one example. What I saw in Sierra Leone, like Sierra Leone used to have a very simple system, like if a baby is born at a health facility, declaration will be done, and the first copy of the birth certificate will be given to the mother before she was discharged. And just because of this, like insistence on issuing unique IDs in real time, now if you visit big hospitals, even in Freetown, you will see that, like health facilities will have stacks of birth registration forms, because even declarations are not completed unless they get the unique ID number from the server. So the message is that we need to have plan B, and plan C. Plan B could be that, like maybe use mobile phones for sending a minimum set of information like name of the baby, date of birth, sex, place of birth. And then in return, the server can send back, like the unique ID number. Even plan C could be that for those health facilities, especially in rural and remote areas, you could issue, like pre-allotted numbers. The idea is UIDs should not become a problem for birth registration. But what I can tell you that, like things are happening in this direction. Thanks.
Thank you. Any comment on cross-border data sharing? Yes. You speak in French? Okay, so let's get our heads on.
Oui, merci. Pour ce qui concerne les besoins de formation, je crois qu'au Togo, nous avons déjà essayé de former, puisque c'est le DHS2 que nous utilisons, nous avons essayé de former au maximum les utilisateurs. Maintenant, le besoin se fait sentir au niveau de l'équipe qui administre les serveurs ou bien la base de données. Donc, nous avons plus de besoin de formation pour l'équipe pour mieux administrer les bases de données de DHS2. Merci.
Thank you so much. That comment? Yes, do we have any other comments in the room? Thank you. Yeah, go ahead.
Thank you very much. I want to talk about the capacity needs. So with regards to the Ethiopian experience, we have this capacity building and mentorship program platform, which brought the academic institutions together with the health sector and has been instrumental in terms of influencing the academic institutions to develop curriculums and open departments in their universities and produce health informaticians, which have been critical in terms of shouldering the routine activities, HIS-related activities at the health facilities and the administrations. So creating such a platform is something that we would like to recommend, a platform that brought the academic institutions and the health sector. But still we have the gaps similar, what Yosef, my colleague, has been raising. And also we have the gaps in terms of, conducting surveys, population-based surveys, especially on regular basis. So this has been critical challenge in terms of, informing the health system, in terms of informing, at the policy level, especially focusing on specific program-based surveys are missing or have been conducted a long time ago. So we have that capacity issue. And we're related to data use, we always try to implement or try to train health managers or the health informaticians to kind of develop behaviorally informed interventions or to interventions to address the behavioral determinants. But usually the interventions are designed in the usual way, and they were not effective in terms of addressing the data use challenges. We have established platforms at the health facility levels and also the administrative levels, which we call them priorities or we have this DP2 project, Data Use Partnership Project, and the work stream 3 is working on applying human science, develop behaviorally informed strategies. So beginning. And I hope applying such decision science related design approach would be critical in terms of addressing the unrelenting behavioral determinants affecting data use practices. So we are aspiring to kind of, scale that and try to address or try to design contextually, context tailored and interventions driven by the desire and the insights of maybe the users. And we hope that these things will be instrumental in terms of addressing the recalcitrant behavioral determinants. And we're looking for any support or any technical resources in terms of applying this type of interventions. Thank you very much.
Thank you. Let's go to the last table. We have Salome and then Bello.
So thanks a lot, Isaac, for coordinating us and the facilitators. Yes, one is popularizing the SCORE methodology in the country. For Malawi, really, it was quite a bit tough to see focal persons, get represented that way, especially where CRVS scores at 67%. But then also currently are reporting the national coverage. I hope, Isaac, it's 100%. We just need to check again. We have GDP to the after that can come up with really we need to learn more from your investments as well, the linkage and investments. Then is HDC at a country level. Yes, we've discussed that before, but we would love to see that partners are like GIA, GIZ, UNICEF, UNFPA. Really at global level, they seem to really be working together, but at country level, it's really preparing us. What you reacting maybe
we realized that project and they what or projections. It's because of lack of capacity.
Think my one country to estimate the past. So the of the working group. How then do we celebrate the coordination when we are not able to like estimate or map the resources that are actually invested into HIS? So we are thinking as a secretariat, but also as the countries that are already under HDC or the countries that are coming on board, we need support either on the methods that we can use to estimate some of these mapping resources contributed to HIS. We think that is an entry point for engaging other stakeholders to come on board and invest into the HIS initiatives. Thank you. Thank you so much. I guess that should be the last comment for the session. We'll now go to lunch. We have 1 hour, so let's come back at 2 o'clock for the afternoon session. Wishing every one of us bon appetit. Thank you.
Recording in progress.
There are many people around the world whose lives aren't officially recorded. People in these left-behind communities are often stigmatized and discriminated against, and counting them can be difficult because of their quasi-legal status.
If you have a section or a sector of the population which are invisible, then you're already having inequality to start with.
Partnerships such as the Health Data Collaborative are crucial. Partnerships like this help countries provide quality foundational data in a better way, which then again improves healthcare quality and health system performance.
We are made up of 7 constituencies: countries, multilateral and intergovernmental organisations, donors, global health initiatives, academia and technical networks, civil society organisations, and the private sector. The power of this public-private partnership gives all of our members 4 key advantages. 1. Aligning to common goals, whether that be the Sustainable Development Goals, universal health coverage, or national goals. 2. Access to a diversity of approaches and ways of looking at problems that lead to better and more appropriate sustainable solutions. 3. Technical and financial resources that can be invested more efficiently because they are centred around common goals. And 4. Decreased fragmentation of reporting and collecting, reducing the reporting burden for countries and frontline health workers. HDC partners can support the best practices of different elements along the journey, including collection, storage, security, sharing, analysis, validation, and visualization. The resulting data helps to plan better health budgets, improves responses to diseases, and saves lives.
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients we have. We are able to understand where to take our services to.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
But collecting health data can, in itself, become a burden.
The issue is that there's so much duplication around what's going on around the world. If we have 190 countries doing 190 things, it's just going to get complicated. Even within individual countries, there are many, many data systems.
The HDC partnership helps to harmonise data collection methods, easing the administrative burden on countries. The HDC have also established networks of working groups to address specific technical issues and identify and fill technical gaps. COVID-19 has underscored the importance of strong data governance for building trust and transparency around data sharing. And while the pandemic has provided a vital new focus on data in the short term, in the longer term, the HDC is focused on the SDG 2030 agenda and goals, many of which are about equity and sustainable institution building.
The SDG agenda, the whole idea is to leave no one behind. So CRVS systems is about counting everyone, because everyone counts.
The Health Data Collaborative aims to empower countries and communities so they can ensure healthy lives for everyone. We do this by 1. Strengthening country health information systems. 2. Aligning partner support for country priorities. And 3. Adapting global tools to local contexts. There are many people around the world whose lives aren't officially recorded. People in these left-behind communities are often stigmatised and discriminated against, and counting them can be difficult because of their quasi-legal status.
If you have a section or a sector of the population which are invisible, then you're already having inequality to start with.
The longer this situation continues, the more people will suffer.
Partnerships such as the Health Data Collaborative are crucial. Partnerships like this help countries provide quality foundational data in a better way, which then again improves healthcare quality and health system performance.
We are made up of 7 constituencies: countries, multilateral and intergovernmental organisations, donors, global health initiatives, academia and technical networks, civil society organisations, and the private sector. The power of this public-private partnership gives all of our members 4 key advantages. 1. Aligning to common goals, whether that be the Sustainable Development Goals, universal health coverage, or national goals. 2. Access to a diversity of approaches and ways of looking at problems that lead to better and more appropriate sustainable solutions. 3. technical and financial resources that can be invested more efficiently because they are centred around common goals. And 4, decreased fragmentation of reporting and collecting, reducing the reporting burden for countries and frontline health workers. HDC partners can support the best practices of different elements along the journey, including collection, storage, security, sharing, analysis, validation, and visualization. The resulting data helps to plan better health budgets, improves responses to diseases, and saves lives.
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients we have. We are able to understand where to take our services to.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
But collecting health data can, in itself, become a burden.
The issue is that there's so much duplication around what's going on around the world. If we have 190 countries doing 190 things, it's just going to get complicated. Even within individual countries, there are many data systems.
The HDC partnership helps to harmonise data collection methods, easing the administrative burden on countries. The HDC have also established networks of working groups to address specific technical issues and identify and fill technical gaps. COVID-19 has underscored the importance of strong data governance for building trust and transparency around data sharing. And while the pandemic has provided a vital new focus on data in the short term, in the longer term, the HDC is focused on the SDG 2030 agenda and goals, many of which are about equity and sustainable institution building.
The SDG agenda, the whole idea is to leave no one behind. So CRVS systems is about counting everyone, because everyone counts.
The Health Data Collaborative aims to empower countries and communities so they can ensure healthy lives for everyone. We do this by 1. Strengthening country health information systems. 2. Aligning partner support for country priorities. And 3. Adapting global tools to local contexts. There are many people around the world whose lives aren't officially recorded. People in these left-behind communities are often stigmatised and discriminated against, and counting them can be difficult because of their quasi-legal status.
If you have a section or a sector of the population which are invisible, then you're already having inequality to start with.
The longer this situation continues, the more people will suffer.
Partnerships such as the Health Data Collaborative are crucial. Partnerships like this help countries provide quality foundational data in a better way, which then again improves healthcare quality and health system performance.
We are made up of 7 constituencies: countries, multilateral and intergovernmental organisations, donors, global health initiatives, academia and technical networks, civil society organisations, and the private sector. The power of this public-private partnership gives all of our members 4 key advantages. 1. Aligning to common goals, whether that be the Sustainable Development Goals, universal health coverage, or national goals. 2. Access to a diversity of approaches and ways of looking at problems that lead to better and more appropriate sustainable solutions. 3. Technical and financial resources that can be invested more efficiently because they are centred around common goals. And 4. Decreased fragmentation of reporting and collecting, reducing the reporting burden for countries and frontline health workers. HDC partners can support the best practices of different elements along the journey, including collection, storage, security, sharing, analysis, validation, and visualization. The resulting data helps to plan better health budgets, improves responses to diseases, and saves lives.
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients we have. We are able to understand where to take our services to.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
But collecting health data can, in itself, become a burden.
The issue is that there's so much duplication around what's going on around the world. If we have 190 countries doing 190 things, it's just going to get complicated. Even within individual countries, there are many, many data systems.
The HDC partnership helps to harmonise data collection methods, easing the administrative burden on countries. The HDC have also established networks of working groups to address specific technical issues and identify and fill technical gaps. COVID-19 has underscored the importance of strong data governance for building trust and transparency around data sharing. And while the pandemic has provided a vital new focus on data in the short term, in the longer term, the HDC is focused on the SDG 2030 agenda and goals, many of which are about equity and sustainable institution building.
The SDG agenda, the whole idea is to leave no one behind. So CRVS systems is about counting everyone, because everyone counts.
The Health Data Collaborative aims to empower countries and communities so they can ensure healthy lives for everyone. We do this by 1. Strengthening country health information systems. 2. Aligning partner support for country priorities. And 3. Adapting global tools to local contexts. There are many people around the world whose lives aren't officially recorded. People in these left-behind communities are often stigmatised and discriminated against, and counting them can be difficult because of their quasi-legal status.
If you have a section or a sector of the population which are invisible, then you're already having inequality to start with.
The longer this situation continues, the more people will suffer.
Partnerships such as the Health Data Collaborative are crucial. Partnerships like this help countries provide quality foundational data in a better way, which then again improves healthcare quality and health system performance.
We are made up of 7 constituencies: countries, multilateral and intergovernmental organisations, donors, global health initiatives, academia and technical networks, civil society organisations, and the private sector. The power of this public-private partnership gives all of our members 4 key advantages. 1. Aligning to common goals, whether that be the Sustainable Development Goals, universal health coverage, or national goals. 2. Access to a diversity of approaches and ways of looking at problems that lead to better and more appropriate sustainable solutions. 3. Technical and financial resources that can be invested more efficiently because they are centred around common goals. And 4. Decreased fragmentation of reporting and collecting, reducing the reporting burden for countries and frontline health workers. HDC partners can support the best practices of different elements along the journey, including collection, storage, security, sharing, analysis, validation, and visualization. The resulting data helps to plan better health budgets, improves responses to diseases, and saves lives.
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients do we have. We are able to understand where to take our services to.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
But collecting health data can, in itself, become a burden.
The issue is that there's so much duplication around what's going on around the world. If we have 190 countries doing 190 things, it's just going to get complicated. Even within individual countries, there are many, many data systems.
The HDC partnership helps to harmonise data collection methods, easing the administrative burden on countries. The HDC have also established networks of working groups to address specific technical issues and identify and fill technical gaps. COVID-19 has underscored the importance of strong data governance for building trust and transparency around data sharing. And while the pandemic has provided a vital new focus on data in the short term, in the longer term, the HDC is focused on the SDG 2030 agenda and goals, many of which are about equity and sustainable institution building.
The SDG agenda, the whole idea is to leave no one behind. So CRVS systems is about counting everyone, because everyone counts.
The Health Data Collaborative aims to empower countries and communities so they can ensure healthy lives for everyone. We do this by 1. Strengthening country health information systems. 2. Aligning partner support for country priorities. And 3. Adapting global tools to local contexts. There are many people around the world whose lives aren't officially recorded. People in these left-behind communities are often stigmatised and discriminated against, and counting them can be difficult because of their quasi-legal status.
If you have a section or a sector of the population which are invisible, then you're already having inequality to start with.
The longer this situation continues, the more people will suffer.
Partnerships such as the Health Data Collaborative are crucial. Partnerships like this help countries provide quality foundational data in a better way, which then again improves healthcare quality and health system performance.
We are made up of 7 constituencies: countries, multilateral and intergovernmental organisations, donors, global health initiatives, academia and technical networks, civil society organisations, and the private sector. The power of this public-private partnership gives all of our members 4 key advantages. 1. Aligning to common goals, whether that be the Sustainable Development Goals, universal health coverage, or national goals. 2. Access to a diversity of approaches and ways of looking at problems that lead to better and more appropriate sustainable solutions. 3. Technical and financial resources that can be invested more efficiently because they are centred around common goals. And 4. Decreased fragmentation of reporting and collecting, reducing the reporting burden for countries and frontline health workers. HDC partners can support the best practices of different elements along the journey, including collection, storage, security, sharing, analysis, validation, and visualization. The resulting data helps to plan better health budgets, improves responses to diseases, and saves lives.
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients we have. We are able to understand where to take our services to.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
But collecting health data can, in itself, become a burden.
The issue is that there's so much duplication around what's going on around the world. If we have 190 countries doing 190 things, it's just going to get complicated. Even within individual countries, there are many, many data systems.
The HDC partnership helps to harmonise data collection methods, easing the administrative burden on countries. The HDC have also established networks of working groups to address specific technical issues and identify and fill technical gaps. COVID-19 has underscored the importance of strong data governance for building trust and transparency around data sharing. And while the pandemic has provided a vital new focus on data in the short term, in the longer term, the HDC is focused on the SDG 2030 agenda and goals, many of which are about equity and sustainable institution building.
The SDG agenda, the whole idea is to leave no one behind. So CRVS systems is about counting everyone, because everyone counts.
The Health Data Collaborative aims to empower countries and communities so they can ensure healthy lives for everyone. We do this by 1. Strengthening country health information systems. 2. aligning partner support for country priorities, and 3, adapting global tools to local contexts. There are many people around the world whose lives aren't officially recorded. People in these left-behind communities are often stigmatised and discriminated against, and counting them can be difficult because of their quasi-legal status.
If you have a section or a sector of the population which are invisible, then you're already having inequality to start with.
The longer this situation continues, the more people will suffer.
Partnerships such as the Health Data Collaborative are crucial. Partnerships like this help countries provide quality foundational data in a better way, which then again improves healthcare quality and health system performance.
We are made up of 7 constituencies: countries, multilateral and intergovernmental organisations, donors, global health initiatives, academia and technical networks, civil society organisations, and the private sector. The power of this public-private partnership gives all of our members 4 key advantages. 1. Aligning to common goals, whether that be the Sustainable Development Goals, universal health coverage, or national goals. 2. Access to a diversity of approaches and ways of looking at problems that lead to better and more appropriate sustainable solutions. 3. Technical and financial resources that can be invested more efficiently because they are centred around common goals. And 4. Decreased fragmentation of reporting and collecting, reducing the reporting burden for countries and frontline health workers. HDC partners can support the best practices of different elements along the journey, including collection, storage, security, sharing, analysis, validation, and visualization. The resulting data helps to plan better health budgets, improves responses to diseases, and saves lives.
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients we have. We are able to understand where to take our services to.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
But collecting health data can, in itself, become a burden.
The issue is that there's so much duplication around what's going on around the world. If we have 190 countries doing 190 things, it's just going to get complicated. Even within individual countries, there are many, many data systems.
The HDC partnership helps to harmonise data collection methods, easing the administrative burden on countries. The HDC have also established networks of working groups to address specific technical issues and identify and fill technical gaps. COVID-19 has underscored the importance of strong data governance for building trust and transparency around data sharing. And while the pandemic has provided a vital new focus on data in the short term, in the longer term, the HDC is focused on the SDG 2030 agenda and goals, many of which are about equity and sustainable institution building.
The SDG agenda, the whole idea is to leave no one behind. So CRVS systems is about counting everyone, because everyone counts.
The Health Data Collaborative aims to empower countries and communities so they can ensure healthy lives for everyone. We do this by 1. Strengthening country health information systems. 2. Aligning partner support for country priorities. And 3. Adapting global tools to local contexts. There are many people around the world whose lives aren't officially recorded. People in these left-behind communities are often stigmatised and discriminated against, and counting them can be difficult because of their quasi-legal status.
If you have a section or a sector of the population which are invisible, then you're already having inequality to start with.
The longer this situation continues, the more people will suffer.
Partnerships such as the Health Data Collaborative are crucial. Partnerships like this help countries provide quality foundational data in a better way, which then again improves healthcare quality and health system performance.
We are made up of 7 constituencies: countries, multilateral and intergovernmental organisations, donors, global health initiatives, academia and technical networks, civil society organisations, and the private sector. The power of this public-private partnership gives all of our members 4 key advantages. 1. Aligning to common goals, whether that be the Sustainable Development Goals, universal health coverage, or national goals. 2. Access to a diversity of approaches and ways of looking at problems that lead to better and more appropriate sustainable solutions. 3. Technical and financial resources that can be invested more efficiently because they are centred around common goals. And 4. Decreased fragmentation of reporting and collecting, reducing the reporting burden for countries and frontline health workers. HDC partners can support the best practices of different elements along the journey, including collection, storage, security, sharing, analysis, validation, and visualization. The resulting data helps to plan better health budgets, improves responses to diseases, and saves lives.
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients we have. We are able to understand where to take our services to.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
But collecting health data can, in itself, become a burden.
The issue is that there's so much duplication around what's going on around the world. If we have 190 countries doing 190 things, it's just going to get complicated. Even within individual countries, there are many, many data systems.
The HDC partnership helps to harmonise data collection methods, easing the administrative burden on countries. The HDC have also established networks of working groups to address specific technical issues and identify and fill technical gaps. COVID-19 has underscored the importance of strong data governance for building trust and transparency around data sharing. And while the pandemic has provided a vital new focus on data in the short term, in the longer term, the HDC is focused on the SDG 2030 agenda and goals, many of which are about equity and sustainable institution building.
The SDG agenda, the whole idea is to leave no one behind. So CRVS systems is about counting everyone, because everyone counts.
The Health Data Collaborative aims to empower countries and communities so they can ensure healthy lives for everyone. We do this by 1. Strengthening country health information systems. 2. Aligning partner support for country priorities. And 3. Adapting global tools to local contexts. There are many people around the world whose lives aren't officially recorded. People in these left-behind communities are often stigmatised and discriminated against, and counting them can be difficult because of their quasi-legal status.
If you have a section or a sector of the population which are invisible, then you're already having inequality to start with.
The longer this situation continues, the more people will suffer.
Partnerships such as the Health Data Collaborative are crucial. Partnerships like this help countries provide quality foundational data in a better way, which then again improves healthcare quality and health system performance.
We are made up of 7 constituencies: countries, multilateral and intergovernmental organisations, donors, global health initiatives, academia and technical networks, civil society organisations, and the private sector. The power of this public-private partnership gives all of our members 4 key advantages. 1. Aligning to common goals, whether that be the Sustainable Development Goals, universal health coverage, or national goals. 2. Access to a diversity of approaches and ways of looking at problems that lead to better and more appropriate sustainable solutions. 3. Technical and financial resources that can be invested more efficiently because they are centred around common goals. And 4. decreased fragmentation of reporting and collecting, reducing the reporting burden for countries and frontline health workers. HDC partners can support the best practices of different elements along the journey, including collection, storage, security, sharing, analysis, validation, and visualization. The resulting data helps to plan better health budgets, improves responses to diseases, and saves lives.
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients we have. We are able to understand where to take our services to.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
But collecting health data can, in itself, become a burden.
The issue is that there's so much duplication around what's going on around the world. If we have 190 countries doing 190 things, it's just going to get complicated. Even within individual countries, there are many, many data systems.
The HDC partnership helps to harmonise data collection methods, easing the administrative burden on countries. The HDC have also established networks of working groups to address specific technical issues and identify and fill technical gaps. COVID-19 has underscored the importance of strong data governance for building trust and transparency around data sharing. And while the pandemic has provided a vital new focus on data in the short term, in the longer term, the HDC is focused on the SDG 2030 agenda and goals, many of which are about equity and sustainable institution building.
The SDG agenda, the whole idea is to leave no one behind. So CRVS systems is about counting everyone, because everyone counts.
The Health Data Collaborative aims to empower countries and communities so they can ensure healthy lives for everyone. We do this by 1. Strengthening country health information systems. 2. Aligning partner support for country priorities. And 3. Adapting global tools to local contexts. There are many people around the world whose lives aren't officially recorded. People in these left-behind communities are often stigmatised and discriminated against, and counting them can be difficult because of their quasi-legal status.
If you have a section or a sector of the population which are invisible, then you're already having inequality to start with.
The longer this situation continues, the more people will suffer.
Partnerships such as the Health Data Collaborative are crucial. Partnerships like this help countries provide quality foundational data in a better way, which then again improves healthcare quality and health system performance.
We are made up of 7 constituencies: countries, multilateral and intergovernmental organisations, donors, global health initiatives, academia and technical networks, civil society organisations, and the private sector. The power of this public-private partnership gives all of our members 4 key advantages. 1. Aligning to common goals, whether that be the Sustainable Development Goals, universal health coverage, or national goals. 2. Access to a diversity of approaches and ways of looking at problems that lead to better and more appropriate sustainable solutions. 3. Technical and financial resources that can be invested more efficiently because they are centred around common goals. And 4. Decreased fragmentation of reporting and collecting, reducing the reporting burden for countries and frontline health workers. HDC partners can support the best practices of different elements along the journey, including collection, storage, security, sharing, analysis, validation, and visualization. The resulting data helps to plan better health budgets, improves responses to diseases, and saves lives.
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients we have. We are able to understand where to take our services to.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
But collecting health data can, in itself, become a burden.
The issue is that there's so much duplication around what's going on around the world. If we have 190 countries doing 190 things, it's just going to get complicated. Even within individual countries, there are many, many data systems.
The HDC partnership helps to harmonise data collection methods, easing the administrative burden on countries. The HDC have also established networks of working groups to address specific technical issues and identify and fill technical gaps. COVID-19 has underscored the importance of strong data governance for building trust and transparency around data sharing. And while the pandemic has provided a vital new focus on data in the short term, in the longer term, the HDC is focused on the SDG 2030 agenda and goals, many of which are about equity and sustainable institution building.
The SDG agenda, the whole idea is to leave no one behind. So CRVS systems is about counting everyone, because everyone counts.
The Health Data Collaborative aims to empower countries and communities so they can ensure healthy lives for everyone. We do this by 1. Strengthening country health information systems. 2. Aligning partner support for country priorities. And 3. Adapting global tools to local contexts. There are many people around the world whose lives aren't officially recorded. People in these left-behind communities are often stigmatised and discriminated against, and counting them can be difficult because of their quasi-legal status.
If you have a section or a sector of the population which are invisible, then you're already having inequality to start with.
The longer this situation continues, the more people will suffer.
Partnerships such as the Health Data Collaborative are crucial. Partnerships like this help countries provide quality foundational data in a better way, which then again improves healthcare quality and health system performance.
We are made up of 7 constituencies: countries, multilateral and intergovernmental organisations, donors, global health initiatives, academia and technical networks, civil society organisations, and the private sector. The power of this public-private partnership gives all of our members 4 key advantages. 1. Aligning to common goals, whether that be the Sustainable Development Goals, universal health coverage, or national goals. 2. Access to a diversity of approaches and ways of looking at problems that lead to better and more appropriate sustainable solutions. 3. Technical and financial resources that can be invested more efficiently because they are centred around common goals. And 4. Decreased fragmentation of reporting and collecting, reducing the reporting burden for countries and frontline health workers. HDC partners can support the best practices of different elements along the journey, including collection, storage, security, sharing, analysis, validation, and visualization. The resulting data helps to plan better health budgets, improves responses to diseases, and saves lives.
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients we have. We are able to understand where to take our services to.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
But collecting health data can, in itself, become a burden.
The issue is that there's so much duplication around what's going on around the world. If we have 190 countries doing 190 things, it's just going to get complicated. Even within individual countries, there are many, many data systems.
The HDC partnership helps to harmonise data collection methods, easing the administrative burden on countries. The HDC have also established networks of working groups to address specific technical issues and identify and fill technical gaps. COVID-19 has underscored the importance of strong data governance for building trust and transparency around data sharing. And while the pandemic has provided a vital new focus on data in the short term, in the longer term, the HDC is focused on the SDG 2030 agenda and goals, many of which are about equity and sustainable institution building.
The SDG agenda, the whole idea is to leave no one behind. So CRVS systems is about counting everyone, because everyone counts.
The Health Data Collaborative aims to empower countries and communities so they can ensure healthy lives for everyone. We do this by 1. Strengthening country health information systems. 2. Aligning partner support for country priorities. And 3. Adapting global tools to local contexts. There are many people around the world whose lives aren't officially recorded. People in these left-behind communities are often stigmatised and discriminated against, and counting them can be difficult because of their quasi-legal status.
If you have a section or a sector of the population which are invisible, then you're already having inequality to start with.
The longer this situation continues, the more people will suffer.
Partnerships such as the Health Data Collaborative are crucial. Partnerships like this help countries provide quality foundational data in a better way, which then again improves healthcare quality and health system performance.
We are made up of 7 constituencies: countries, multilateral and intergovernmental organisations, donors, global health initiatives, academia and technical networks, civil society organisations, and the private sector. The power of this public-private partnership The Health Data Collaborative aims to empower countries and communities so they can ensure healthy lives for everyone. We do this by 1. Strengthening country health information systems. 2. Aligning partner support for country priorities. And 3. Adapting global tools to local contexts. There are many people around the world whose lives aren't officially recorded. People in these left-behind communities are often stigmatised and discriminated against, and counting them can be difficult because of their quasi-legal status.
If you have a section or a sector of the population which are invisible, then you're already having inequality to start with.
The longer this situation continues, the more people will suffer.
Partnerships such as the Health Data Collaborative are crucial.
reflection.
Mr. Chair, can we start the session? Thank you so much. Good after lunch, colleague. I hope we enjoyed a good lunch. I and my colleague Melissa will be taking you through a series of presentations, 2+2's Q&A sessions for the next, I think, 2 hours. So the first presentation hereafter is the HDC leadership events and webinars by Carolina. I think it's a visual presentations. Carolina, the floor is yours to present to the audience.
Thank you, Chair. Hello again, everyone. Next slide, please. We'll talk about a little bit about any upcoming communications and events at our collaborative. And next slide, please. Or at least it's not moving to me. Okay, thank you. Right. So this is just a recap of an event we had back in May this year on the 18th and 19th of May. And we focused on reviewing data governance principles and then discussing and promoting an HIS investment strategy to strengthen health information systems at country level. And you hear, just after me, you hear more about this investment case from Xavier, our colleague from Swiss Tropical and Public Health Institute, who undertook this work. And back in May, they were halfway through, or at least 80% through the process. And now we're finalized with that work. And he'll present their main findings and discuss what's next for investing in health information systems or investing better in health information systems for supporting countries. Right. Back in May, we had with us government representatives from a series of different countries, and I'm very glad to see some colleagues or at least representatives from the same countries and governments who joined us back in May. So it feels really good to see a continuity in this advocacy effort. And then the agenda highlights for that particular event. We focused on looking and learning from country practices in good data governance. We looked as I've mentioned, ways to strengthen and strategies to strengthen HIS in countries. And then we wrapped the event up with a roundtable on investing resources, much of what you've heard as well here. And again, we are focusing and walking towards the same goals, which shows that we are keeping it consistent in what we're trying to do in terms of communications and advocacy for and via the Health Data Collaborative. And we wrapped our event with a 4-point call to action that included promoting or advocating for a health data governance framework, making the HDC ever more focused in countries, looking at issues of capacity building, identifying national and regional institutes to build capacity. And I'm aware that you've discussed this today as well. And then the advocacy and communications piece, which is also a key next step, so to speak, that helped build momentum also for this meeting we're having today. Thank you. Next slide, please. Right. So a part of, as you know, this is an outdated slide. Sorry. Pandula, do you think the next slide is the updated version of this one? Can you please move one forward just to check if, no, it's not. Okay, you can go back now then, please. Thank you. Okay, so this is a bit outdated. This text has been updated. Maybe it just didn't load in the system, but we are having, so one of the key features of the HDC is, as I've mentioned just before the launch, the knowledge brokering role that the collaborative can play and that we can use to advertise or advocate for different products, tools, initiatives. And this specifically is the webinar that it's coming. It's on the 13th of December. It's going to be 10 a.m. EST time. So the CET time is wrong. It's 6 to 7:30 CET time. And next Wednesday, we're going to hear from a joint work between WHO, UNICEF, and Johns Hopkins University, a specific center, working together, improving estimates for child, adolescent, and young mortality estimates. So they will discuss how their collaboration was born, how it became something that could deliver measurable impact to countries, and then they will showcase how to use the online tool that is available for all countries to tackle the subject. So this is just one example, and it's the upcoming one, and you're absolutely all invited. We have circulated an invitation via calendar to the mailing list, but we'll also add it to our outgoing communication via the newsletter. You'll find the link there as well to connect. There's no password, there is no, it's a webinar, so you really just click the link and you can join, and you can tune in for as long as you want. It takes an hour and a half, as a standard for all HDC webinars. And then we usually take the first hour for the presentations, and then the second part, the half hour that's left for questions and answers. And it's usually a very fruitful space for people to interact. Sometimes maybe they've never heard about the subject. Sometimes they've heard about it, but never really got deep into specifics of that particular subject. So it's always great it's as a learning, as a knowledge exchange activity, is always great to join and tune in. So we'll make sure to circulate the invitation as well via the newsletter. Next slide, please. And then this is just an invitation for you to make use of the HDC's wide reach. We do have in our membership a wide range of countries, regions, organizations, and partners. So if you're working on peer-to-peer engagement and learning, or if you're developing something on advocacy and communications for HIS, or if you have a knowledge project or that is strictly linked to country priority that you would like to disseminate, or even your working group activities, as Doris was mentioning just before, it is always important to talk about what we do at the level of the working group, because there's a lot of effort put into it. Please feel free to reach out to the HDC Secretariat. It's the same email that we use to communicate. It's the HDC Secretariat at who.int. And then you can present your work to share good practices, tools, guidelines, experiences, peer-to-peer learning opportunities, data and digital health initiatives, or if you're a country looking for a place to showcase any successes or challenges that you have just to complete a piece of your work. For example, we had earlier this year, Guinea was a champion country for the telemedicine. Guinea-Bissau was a champion country for the WHO telemedicine guidance. And then they've presented, how far they could advance on implementing the telemedicine guidance, and then what were the gaps. And then from those discussions, you can have other partners engaging, either to help you address a gap or to even connect and contribute further to to your health data efforts. So this is just it's a ongoing invitation. We have monthly webinars, but if we need to, we can accommodate 2 webinars per month. It's not a problem. So just please feel free and reach out to us via the HDC Secretariat mailbox. Thank you. I think the next slide I will hand over to Xavier. Oh, sorry, feedback and questions. Yeah. Back to you then, Chair. Thank you so much.
Yeah, thank you so much, Carolina, for a nice presentations. Yeah, we'll go for feedback and questions as my colleague Melissa is also preparing to take on the other sessions. But I wanted just to just now allow the floor for comment, feedback, and maybe questions. The floor is yours. Okay. So silent means everything is okay?
One of the reasons why it was prioritized is because the issue came up in the evaluation that the HDC wasn't communicating as effectively as it could do to country colleagues. So you may not have any answers now, but please, if you have suggestions on how best to communicate with you and vice versa, let us know. We thought about using the website more. We've used different channels of communication. But if you have something that's working already in another fora, let us know and we can build on that. So we're really keen to improve communication 2 ways. So you can feed back to us, but also we can disseminate information on your behalf as well. So any room for improvement, let us know through Carolina and through the Secretariat. Thank you.
Thank you. Yes, Doris.
Just a remark. I mean, using HDC to publicize an event, can be misleading in a way. I mean, if you look at it, I don't think that HDC is with the examples about the maternal and whatever it is, So that's a bit uncomfortable about that, It looks as if the idea that HDC is doing that. It's not. No, not at all. So maybe that should be clarified, This is a sort of secondary role of the HDC, not the primary role. I think that we should try to avoid this sort of mixture, because even in my head, I got the idea, oh, HDC is doing that job, it's great. But then, countries can think of the same way as I'm thinking. So we may have to say that using HDC as a conduit, as a route, to disseminate other work. But as it is shown, it's quite misleading.
Yeah, thank you so much. Of course, actually, HDC, according to the perspective of so many countries, like my countries, is a forum for data sharing and sharing of the best practices. And what we're actually looking at the 4-point calls for action on the health data governance, the capacity building through the country, frameworks, and advocacy, capacity building, So all these things are linked to the existing structures in HMIS governance in the country. And to do this through the government structures will make it more easier than putting it like a standalone. In most of the country, capacity building is a song being sung several times by development partners, that we are trying to build the capacity of the Minister of Health and all this. And what comes with that capacity is the signing off of those partners. So if the Minister of Health has a capacity to stand on its own, they will not be there. And there is no man or a woman who is brave enough to sign off his or her own death certificate. So you really need to do it through the government mechanism. To do it through the partners and all this, trust me, 100 years to come, we'll still be at this stage. So it's a nice presentations, and I would give more chances, 2, 3, because we wanted actually to keep this session short as we are closing, and we also want to see Nairobi. We can't just be here and then go back, you see? So let us just be mindful of time. 2 more comments on the ADC governance. Okay. I will hand over mic to Melissa to just take the floor and maybe if she had a comment.
Thanks, Matur. Good afternoon, colleagues. I actually thought there were comments online. So just checking in case there were any comments or questions on the first presentation. Okay, all right. Shall we appreciate Carolina? Okay. So in the Kenya way, we had a president called Moi, and he socialized a certain way of clapping. So I'll just do that and then we repeat. For those of us who are familiar with the Kenya context, you know what this is. So I say, moja, mbili, tatu. We will not open and close. I don't know what he meant by open and close. There was opening and then closing. So we'll just do 3, 3, 3. So, okay, let's prepare. We are thanking Carolina for the presentation. Okay, 1, 2, 3. Thank you. Thank you. And now we are ushering in Xavier to make a presentation on the investment case. And then we can have more, more interaction after that. Take it away.
Hello, good morning. I take that you hear me. Thank you. Yes, I am in Ghana, so my connection will be a bit unstable.
Xavier, you're cutting. Sorry.
Twice from the Zoom room. I don't know if by my computer or by your. Yes.
Great, thank you.
Yes.
You may proceed.
Okay, so if there is a problem with the connection, thank you. If you see that this is not working well, please write in the chat. I have the chat window open just in case. So please, next slide, please. Yes, well, first of all, thank you very much. Thank you for I am presenting on behalf of the whole team of teachers that this assignment for a few months. And I will try to go through the methods, the main key findings, and then the synthesis that we call the new paradigm. Next. So we understand the routine health information system that you can see represented in the right side of this slide as this data collection in health facilities that then is flowing towards the higher levels, managers down, also down to policymakers and
I'm sorry.
The side of this slide where you see the statements. Yes.
The line is really choppy. The connection is a bit choppy. I'm not sure whether it can get better.
Policymakers and a national. Yes. Should I continue?
It's a bit choppy, but let's continue and see how it goes.
Okay. I was saying that the left side is the universal health coverage statements. And the key issue is how do we link the universal health coverage and eventually SDGs with the right side of this framework, which is the decision space that here is represented with is represented with diamonds. And what we aim is that at each level and in each dimension of the routine health information system, this is truly informing decisions.
I'm so sorry, the connection seems to... Hello, Xavier, can you still hear us? Hello, can you hear us? I think we've lost him. Yes, great.
Can I suggest that if Carolina is still online, whether Carolina could present on behalf of Xavier, because Carolina has been involved with the work, if she's still online. Otherwise, I can try and present on his behalf. Okay. Carolina, if you're online.
Thank you, Craig. Hi, Carolina. Can you still hear us? Are you still online?
Yes, I just had a little connection issue. Could you please repeat? But I'm here. I hear you well.
Great. Thanks for staying on. So Craig is proposing that if you're comfortable to continue the presentation, that would be great, because we seem to be having a connectivity issue with Xavier.
Xavier,
Thank you.
Xavier is back. Are you back, Xavier? Craig, maybe it's, do we have anyone from the WHO HIS group either here or online? I think they're better placed or better suited to have this technical presentation. Or yourself, if you're...
I don't know if there's anyone from the RHIS
maybe
working group who's
Anne. I'm not sure if Anne is online or Rifat. Craig, I think it's best if you go ahead. I think it would be better for the audience if it comes from someone knowledgeable. Thanks.
I'll try, unless I request is Anne Shu online from the RHIS working group, who's also familiar with this work. Okay. If not, Xavier, if it's okay with you, I'll try and take the audience through the slides and the background to it. So I would go through, I'm not familiar with this slide, but just a bit of background so everyone is aware. This work was commissioned by the HDC, specifically the RHIS working group. So this is a good example of how a working group saw an opportunity, saw a need, the investment case in RHIS. The Swiss Tropical Institute was commissioned to undertake this work. They led it with guidance from the RHIS working group and also from an external group of experts. And over the space of about a year, they undertook a series of a literature review. All this information is on the HTC website. They undertook 6 country case studies and made what was supposed to be an investment case, but it became really difficult to make the investment case because of basically a lack of data to actually justify that. One of the issues that came out yesterday was how do you define HIS and what's an investment in HIS was one of the key issues, as well as estimating the return on investment. So next slide. So obviously one of the problems I think everyone in this room knows is the not only fragmentation and parallel systems of reporting information from facility level up the way, which is disease or program specific, but it's also the issue of donors and key partners wanting their own information set in different formats, which of course increases reporting burden all the way up the chain from healthcare workers to national level as well. I think everyone's aware of that. And unfortunately, I can't respond to the graphs on the right-hand side. Apologies for that. Next slide. Yeah, another more important. So the previous slide, I think, demonstrated the burden that I mentioned yesterday. Some studies suggest up to a third of a nurse midwife's time is spent unnecessary reporting in different forms and different parallel mechanisms. That takes up a third of her time. So we talk about a human resource crisis. Here is from an investment point of view, here is an efficiency point of view that could really have an impact on the human resources as well if we were to make her life quite a bit easier. Next slide, please. So the methods that I said I've highlighted, there was a scoping review, there's case studies in 8 geographical areas. I think there were 6 countries, economic analysis and a synthesis as well. And that was released in the workshop in Geneva, which helped contribute to a lot of the discussion around investing in health information systems in May. And again, that report is available on the HDC website for those that are interested. Next slide. Yeah, and the findings, and again, apologies, you might get bored of my voice, I'm speaking too much, but Xavier, I wish Xavier could present it. He could present it in a lot better fashion than I can, but I think the findings, the main findings are 65 million health workers worldwide routine health information systems.
Greg, I think Xavier is back.
Okay, Xavier, do you want to take over from here? You're on slide 3 and findings, if you're there. Thanks.
Yes, I will try to my mobile phone. Maybe it's better. I don't know the reason. Let's try. If not, you tell me. Yes. So we have. So this is really a summary of things, very synthesized. In the first one of them is really to realize routine health information health services. So more than 60 million health workers worldwide are using it every time, every day, across all health services. So this is really something very specific to routine health information systems. On the other hand, when with the scoping review, we realized that the approach of using routine of investment cases, this is not so practical when we are looking at non-pharmacological interventions, basically because we have a problem of attribution of or the relationship between investments and outcomes. The country case studies showed many interest, of course, issues related to inefficiencies that are to give you some small pearls of the findings. We estimated that the governmental health budget dedicated to routine health information system was less than 1% and much less in some of the countries. Most of the running costs are held by human resources and particularly at peripheral level. These are costs that are not imputed as such to routine health information system, but every minute that someone is actually recording or reporting in the data, this is a cost for the system. And we have estimated that the annual person time in hours in a country spent in routine health information systems is at the level of millions of hours. Like here we have 2 cases, like 8 million in Cote d'Ivoire. For even if you would like to say that this is an overestimation, which we might agree in terms of methodologically and so on, but this is really an extraordinary number of hours for a business or a system to work on. Next one. So basically, what we have came after several discussions and many goes and backs and looking at the findings as well, is that we need a change of paradigm. Up to now, we have been operating mainly looking at data and dashboards as if these were kind of the silver that information system quality of care tool. Quality of care, I don't mean only and mainly like quality of care of hospital and hospital infection and so on. Quality of care in the sense of access, in the sense of the universal health coverage concept, which is to have access to preventive, curative public health services in a area. I think that traditionally we have used quite a technocratic approach where the focus on. I have been spelled again. Can you hear me now?
Record. Kindly continue. Hello, Xavier is still online.
Thank you. Sorry. So I will go fast to this, but basically also we need to look at the health information system as something that is used by health workers. So we have to introduce really the concepts and methods of human-centered design. Also, when we look at the use of data, I think that this is quite speculative. We are always saying use of data, but what are actually the decisions, the precise decisions that each different actors have to make? And these are very different for a frontline health worker that makes a difference between life and death with a patient and a health manager or a policymaker. I also think, we also have look at this in terms of the health workers' roles, and certainly we have to stop blaming health workers and to organize thousands of trainings for a system, an information system that is ill-designed. We have really to improve the design of the system so as to make it actually seamless for health workers to work with. In terms of research, I think we have to move to more experimental research designs because there is really a lack of robustness in research on health information systems. And then we have to move from doing research also on pilot experiences on very small health information that of course can work for a given period of systems research or at harms of the potential harms that we can have with certain routine health information systems. And that would be all from my side. I really apologize.
We've totally lost you. I don't know whether you can still hear us. Hello, Xavier, can you still hear us? Are you still online with us?
Yes, I am. I was hearing you. I for synthesis paradigm change, and I apologize for the connection.
That's okay. I think we can proceed.
Yes, please.
I didn't realize that was the last slide. Thank you so much, Xavier, and thanks everyone for bearing with us through the choppy internet connectivity. So let me open the floor and to our online audience for any questions, any feedback you might have, any additions. We'll just take 3. Okay. Anyone from the floor? Any questions or any kind of feedback, even from our online audience? Any clarifications from our WHO colleagues? Okay, great, go on.
So I saw that typically in the past, like the dashboards, he put an X, okay, on the dashboards. And I don't know if you can go back to the slide. So does that mean that dashboards would be no longer implemented, or they'll be implemented to be showing quality of care, you see? Or we have a more informative dashboards rather than just showing just the information. I just want to clarify that.
No correlation between the two.
Okay, Xavier is still online. I'm not sure whether you had Doris's question.
I didn't hear the question. If you could repeat that for me, please.
Okay, the slide is on the board there. So talking about paradigm change. So you have data dashboards, and then you put an X, which means that was a past. And then the future, is it something like you want a dashboards which is linked with quality of care? Or I don't know. It's just I don't see any correlation between any of the things on the future regarding the dashboards.
Was it clearer?
Yes, I think that the point that we are trying to make, yes. I think that the point that we are trying to make is that the emphasis is usually in doing very nice data presentations, very nice graphs, and also that's totally fine. We have to do that. But actually, we understand that the health information system is about improving healthcare. It's not about creating nice data that is hardly used. It's really to make the emphasis on quality of care. And if you look at the routine health information system from the perspective of healthcare, then some other things become more important than others. And it's much more important, according to this paradigm shift, is much more important first about decision making, and then later on, only later on, once we are clear about what decisions we have to make, then think about data and about dashboards. And we are operating the contrary. We are building very nice dashboards, and then we say, well, make decisions with this. Well, I don't need that. The decisions that if we don't have an analysis of the decision space, we cannot know what data and information is required for these decisions. Over.
Yeah. Thank you, Xavier. So what you're saying is that, so what you're asking is that the data is, the dashboards are actually used to inform decisions that then are able to improve on the quality of care, right?
Yes, but I think also we have to stop thinking about data and indicators. Hello? Yes?
It's okay. There was a second question. Hello? Hello, Xavier?
Yes, go on.
No,
yes.
it's okay. There was a second question.
I hear.
Hi, can you hear me now? Hi, okay.
I hear you.
Okay, great. Yeah. My name is Rose Damini. My question is, okay, now we have the investment case. So what do we do? What next? Thank you.
Well, so you are saying what do we do next? I think that someone has to make the paradigm. Someone has to make this decision. It is not me, I don't have power, but someone has to make this decision and start bringing here new brains, new people, and stop those that have been thinking up to present to intervene. We need really a shift, and this can only operate if I think you see WHO and so want to put this truly innovative approach into the table. Catalan, we have an
That's okay, Xavier. Thank you so much, and apologies for the connectivity. Did we have any questions from the online participants? Okay, so kindly, yes, Craig.
So I realize Xavier's line is bad, but to answer your question, Rose, in terms of what next, again, we're guided by you, but this was a piece of work that helps highlight what it would take to invest in health information systems and possibly give you in countries some more ammunition, some more weight, some more evidence for why investing in health information systems is important, number one. And secondly, what Xavier's team are suggesting is it needs a new way of thinking about routine health information systems. And that's what him and his team are advocating for. And I think lastly, based on May's event, when we convened a group of stakeholders together, we want to try and, as we move forward, make a more comprehensive case for investing in better data governance and investing in health information systems. And this is one strand or one piece that helps us with that, along with our colleague Karen, who was here yesterday from the data dividend work, which is broader than health as well. So it's basically a piece of evidence that could be used to lobby, to advocate for when you're talking about why people should invest in health information systems. It's one piece of evidence of which there's quite a bit out there. We're trying to kind of pull it together more in terms moving forward of looking at better investment in health information systems, how to do that, specifically routine health information systems, and better data governance, which is going to be part of the data dividend work that the other group is working on? Thanks.
Can I make one observation? I think this is an excellent study. We have been struggling. When I joined Tanzania in March 2016, that time the health sector had close to 120 systems and subsystems. And by the time when I left, it increased from 126 to 142. Okay. And I can tell you the starting point has to be, simplification of the reporting process. Okay, and we have to make it optimum. There's no point in collecting same information across different registers. So there has to be a governing register that should feed into, all different registers. So I really liked, sorry, I was not, I couldn't attend the initial part of the presentation, but I really liked it. And thank you for that.
Thank you. And I like the idea that the whole, I mean, all the work is to reduce the inefficiencies. I guess that's, the main selling point. And thank you so much. I guess we can definitely come up with different advocacy toolkits or products from this work. So allow me to move on to the next presentation. And okay, so if we still have online, our next presenter on partner mapping, Pandula, if you're online. Oh, great. We have Pandula in the room. Goodness, I'm so sorry.
So thanks, Chair. So what we're going to kind of demo today is it's still in the prototype stage, and we would like your feedback and guidance on it as we move forward. Now, I think during the last annual stakeholders meeting, one of the things, it's the SRG meeting, I think, one of the things that came up from the perspective of the partners as well as the countries is that what are the how do we map between what the countries need and what the partners are able to support with, and how do we map? Do we have that intelligence with us in order to do that process? And if so, what's the framework that we can use, and what's the platform that we can use for it? So this was the basis of designing the partner mapping tool by the HDC, and I must acknowledge the contributions by one of our HDC members and a regional institute, the Health Informatics Society of Sri Lanka, and the WHO Center of Excellence in Health Systems Policy and Innovations of the Faculty of Medicine, University of Colombo, for their support in the development. So I will stop sharing the slides now, and we'll go directly to just give me a second. Right. Okay, so I don't know why. I should try singing. Yeah. Testing one. Oh, great. My singing career is quite short. So the mapping tool, as you can see, is at the moment has a login, and we have shared the login with some of the countries who are here. And thank you for those who have championed the cause and updated the country profiles as well as some of the projects. The partners that have already updated some of the projects in some of the countries. So the idea is for this to be a platform where the countries, the partners, the regions, and anyone who's interested in knowing what the partners do, what the country needs are, and how that can be bridged or collaborations can be formed for everyone to use. So when you sign in to this using the username and the password that is shared, We haven't included any fancy stuff so far, so this is still a prototype. It can change as we speak. There are certain things being developed also. One of the first things that we have is a country profile for the Ministries of Health, whoever in charge of health data in that particular country to update. And one of the frameworks that we have adopted in this tool is to use the score as a way of bridging between the information that is provided by the countries and the partners. So what you see here are some of the updates from different countries. Some of the countries have not fully updated the profiles as yet, but some have. For example, I take the example of Sri Lanka here. Thank you, Dr. Palita, for supporting this activity and mobilizing support for it within the Ministry of Health. As you can see, we collect key information that will be useful for countries to both depict their health information data system needs, as well as useful for the partners' perspective when they plan investments or when they plan engagement with countries. For example, the basic details related to regions, income group, and so on. And then we also gather the budget cycles with the expectation that partners will value that information as they engage and plan their investments. And also, we would like to know whether there are any strategic plans within the country. And this may be a strategic plan that is standalone for HIS or embedded within a much broader strategy that we would want to know, because then partners will also follow that as against having their own agendas. Engagement with HDC, we want to know because it's a formal process at some point. So whether that has happened, that's the information we gather from there. And then the coordination mechanisms, whether there are already available coordination mechanism existing within the country for health sector development partners, as well as for partners investing or supporting HISs. So we want to know that information, because then the partners or regions, when they engage, they know the mechanisms that are already in operation rather than formulating new. Then we have the score assessment, which was done in 2018, and this can be updated as we move forward. This was not done manually because we have got the score details from the score team at the WHO, and we have used that information to update, but we can always update it as the new score assessment is done. Then we move on to an important element in this form, which is the top 5 or the 5 HIS or data system priorities of the country. So what we have requested the country is to let us know up to 5 HIS priorities in terms of its name, the description. And here we ask them to see whether they can classify that priority using elements of the score. So for example, if it is a CRVS system, they might classify it under full birth and death registration or certification and reporting of cause of death. So you can use multiple score areas to classify this. We also want to kind of know if there are any assessments in terms of budget, and also any keywords that they can use to classify or further describe this particular system. The keywords are important because then when the partners also use the same type of keywords, it's easier for us to map and identify which partners can actually meet with these needs. And that's an additional sort of classification to score, so that we have multiple ways of classifying. So once that information is done, then we have an option to add it to a table. I think Sri Lanka has updated it with about 5 health information system, data system, digital priorities here. And lastly, we also ask the partners who are already contributing in the country to HIS health data needs. So we have a list of partners as well. So this is what the countries will provide. The countries will manage it themselves. The login will help countries to keep it secure and then update it themselves. As the admin, I can see it, but then it won't be possible for any others to log in to and update the country profiles. So it'll be something that the countries will manage for themselves. And the second part of this mapping tool is, of course, the involvement of the partners and what they do in a particular country. So as you see, there are a few updates with regard to Sri Lanka, Nepal, and what the partners, or sometimes this may also be the Ministries of Health who are updating this. It may not necessarily be the partners. A partner can update not necessarily projects, but any intervention that they do. But these are current interventions that we have asked, not necessarily the interventions that they have done already. Maybe at a later point, we can probably gather that as well, but the current engagements. So we ask who the partner is. It may be, say, for example, Bloomberg Philanthropies, the target country. They can select the program name, when it started, end date, it may be in years. And we also ask nature of project, whether it's a pilot or implementation, whether it's a research, and so on. And also we want to know whether it's a national or a subnational system, because just because the engagement is there, we doesn't know whether it's impactful across the country. We also want to know whether the private sector or civil society is involved in it, because that's an important area for the HDC to know whether that has been happened. A very brief detail about the project, any details that they can be provided. It's just about 100 words. Few descriptions would do. Then we also ask them to basically say, okay, what's the health system contribution from that system? So this is the same keywords that we use. And you can have multiple of those, keywords added depending on the project. Then, of course, the partner involvement, we also ask the same question we ask from the countries about classifying the HIS priorities, that is to classify it under the score areas. So it might be multiple score areas or 1 or 2 areas. Under each of the score areas. Then another important questions we ask is, okay, what's the resource or the input that the partners are bringing in? So at the HDC, we have been looking at 3 key things: the funding, technical support, and advocacy or political engagement. So these are the 3 things we are asking. At the moment, we don't ask specifics related to it, but whether the partners are bringing in funding, whether they are bringing in technical support, or all 3, advocacy or any other. So they can add. Then the next follow-up question is about who are the other partners involved. Like, for example, Bloomberg might work with AHIN or Gavi or any other institution for that matter, depending on their engagements. So we can also say, okay, in that particular collaboration, what's that partner is bringing in? Is it only technical inputs? Is it only political or advocacy, and so on? So we can define those as well. One last question of importance here is the global public goods. If there's any global public goods being used in this particular project, for example, it may be DHIS2 or any other toolkit that is available. What that basically helps us to do is to map who the partners or the countries already have experience in those global public goods, or the partners who have already invested or contributed to those global public goods. So when the country needs a particular system being implemented, then we know who the partners that needs to be in the table to discuss this. So this is basically the information that that we gather from the partners, or this sometimes in Sri Lanka, it's largely both the ministry as well as the partners updated this with regard to projects, but in Nepal, it was the partners who updated their own details. So it can happen in either way. Mapping, we have not yet gone into much detail, but I'll show a few things that can be generated through this. One is, say, for example, this is region across for zero. Across region in contributions by partners. For example, in relation to technical inputs, funding, advocacy, and which score areas are being populated through that engagement. So this potentially, when you have that information within a country, could lead to identifying which score areas may be lacking in terms of investments, which score areas are having heavy investments, and so on. So similarly, there are several visualizations being developed as we speak. We are trying to see the best, the cross-matching, how it can be done. This is in terms of area of contribution to the health system. You can select specific areas. For example, if a country wants to know who are the partners who can contribute to, for example, human resources related matters, then if there are any who have listed human resources as one of the contributions, you will get to know. So this is some early visualizations of this tool. So basically, this is what we have at the moment, the prototype. Of course, the hardest thing will be to implement and scale it up, and of course, to sustain. We value your inputs in terms of both improving what we gather and what we visualize, and how best this may be implemented as we go. Of course, just to add, there are other visualization tools that we also have looked at. For example, the Digital Health Atlas or Digital Health Monitor. These are tools that probably serve a particular purpose, and this we think is what will serve the partner engagement and mapping between the country needs and the partner engagement. But in the long term, it would be ideal to link in with these platforms as well. So I'll stop at that. Thank you for listening. Happy to answer any queries you have. Thank you.
Thank you so much, Pandula, for inside presentation. In fact, I happen to be one of the participants online, so it is really very, very interesting. So now we are actually vying the schedule. The time is running so fast. I would request the floor to give in their feedback and maybe questions, comment. Yes, from Malawi.
Yes, this is Mikhail Waga, Strategic Health Information Officer, WHO Malawi. And I have a couple of questions based on your presentation. One is the system capturing funding that comes in, because I'm not sure if there is a timeline. I haven't disclaimed, I haven't logged in myself. But if there is a funding timeline, because usually, for instance, in the WHO, according to the planning, there is funding that is allocated towards Pillar 4, which is where this HIS falls under, right? And then during the course of the year, there are other projects and other partners who come in and are able to fund certain aspects as well. So is the system able to capture that? And then also from the government side now, I think this is both for the partners as well as the government, and it's more or less the same, it's more or less similar in how it is structured. Does that incorporate, is that incorporated in the government side as well? And then secondly, is it measured based on the anticipated funding that is, because when the funding comes, they say this goes to this area, but then it's estimated. But then after you have input the top tasks, then that's when you know exactly how much has gone to a certain activity that is supporting the health information system. So does this capture that? And because you're only able to know the exact amount probably at the end of the year thereabouts, is there an allowance to actually go in and change? And is there a possibility to measure what was intended to be set for these activities in the beginning vis-a-vis what has actually gone into the activities?
Yeah,
thank you.
Thanks for that question. So if I may talk about the tool at present, it doesn't capture any values except from the countries about their estimates of a priority. But we do capture what the partners bring in terms of either is it funding, technical, or in terms of policy. So to that extent, we know, but we will not know how much at the moment. The other thing is what we want the partners to update or the ministries to update is the current ongoing projects. Not the ones that probably have been planned or the ones that have completed. So we want to know what the current status is. And that means we have the timelines to say that, okay, this project starts from this day and end beyond the entry date that we are having in this. So yeah, that's the information that we gather. And the third thing is the country portal is for the state. Whoever manages or who's the custodian of the health data in that particular context, and they can update that information themselves. So the country information portal is accessible only for the Ministry of Health, for example, in this case to update their profiles. But apart from the values that they may put, which is also optional for each of the priorities, they don't describe any other costs or projected funds that they need in this particular tool. But these are good things for us to probably think as we move forward how that investment scenario be built in within the tool itself. Yeah, thank you. Did I answer all the questions? Okay, right, thanks.
Yes.
Thank you for the good presentation. This is just one proposal that probably amongst all what you're asking for, if you may ask on the technology products as part of what you're asking for. The technology products, huh?
Right. So from the partners, we gather the information of global public goods, which includes some of the technology products that are there. So we are thinking there were suggestions that for us to link up with the Global Digital Health Index or the Global Digital Health, what do you call it, the directory, where you have a lot of digital tools have been listed out as part of the, the list that we provide, which we probably will look into also. But that is the place where we can actually capture any technology products that the partners may be investing in or using in that particular project.
Yeah, Malik.
Thank you for the opportunity. I attempted to go through the form to actually provide the data for South Sudan. However, I noted some issues that I wanted to share with you. For instance, for the lead partner, if the partner is not listed among the drop-down options, is there any provision to type in, the partner that is not among the list? And secondly, if you go to the geographical scope, you have national and subnational, and there could be you might have a project that could be implemented at both levels. So are you able to select the two? For instance, if it is both for national and subnational. Okay. So these are things that I thought is important to share with you.
Yeah.
And also there is a request to upload the project files. Sorry? The project files.
Okay.
There's a request to upload the project files. So, and for some projects, they could be very bulky. For instance, World Bank funded projects. They could be like in over 200 pages. Are you asking for the entire project document or just a section related to health information? Because some projects might include health information and other, components.
Yeah.
Thank you.
Yeah. Thanks for the suggestions also. Yeah, the drop-down list needs to have an option of other, but at the moment what we are doing is, depending on the partners who are feeding in, we add it in the back end by an administrator. The list gets updated. But as we develop further, we will have the other option also, for the development. And with regard to the uploading of documents, these are optional, so no need of uploading to complete it. But they can also give a link to whatever the documents that are there, so that if somebody wants to get into details about that particular project, so we have the information in one place. So yeah, but ideally we would want whatever the information they can provide, so that when somebody wants to refer, then we have that information already. But as I said, yes, you said, understand that the bulkiness of some of these documents. Yeah.
And for the national and subnational?
We do get that information as a project or a program is updated by a partner or by the ministry, but visualization we have not done so yet. But then we can, since we have the data, we can play with it and come up with that information as well.
Good.
So, sorry, Bashka.
So what will be reported for like countries that have not yet reached full birth and death registration? Because I saw in your scoring criteria, like full birth and death registration was one of the assessing points. So are you trying to follow a binary approach that have achieved full birth and death registration get 1 and the rest gets 0?
Well, at the moment, we are following the same score assessment grading system in this. So it will be the same identifiable, the colors that you see here is the same as a score assessment. But we depend on the score, probably the next evaluation, for it to be more updated, because some of the countries, what they mention is the score value that is there has changed and it has, moved on. Probably that is not a true reflection of this. But what we can show, we won't be able to go into granularity and say whether that's achieved unless the score depicts it. We won't be able to say whether this is, fully achieved 100%, even at that present, instance. But I guess what we can show is that when there is a gap, is the investment right in terms of where the gaps are within the scope? So I think that's what we wanted to show as a first thing, whether the investments or the partner collaborations goes into the places where we recognize as there are gaps, which is recognized through either a red or an orange or whatever the color that may be. Yeah.
Thank you so much, Fandula. Actually, we have another presentations, and I would suggest, since this is a practical sessions and Pandula is still in the room with us, we can have a sideline discussion with and show us exactly how the tool works. But ideally, the tool is to map out the partners supporting the health information system in the country to avoid the duplications. And it is all actually, tailored in a way that you can enter the information that you think, okay, is actually being funded. The activity is being funded by a partner. So what I would just add on what Malik said, there are some of the partners that I've seen here in the drop down that they are donors. Like Global Fund is not, for us, it's not a partner. The Global Fund is a donor, and a partner is either UNDP or ICAV or maybe Court 8. So there is a need for a provision to type in the partner, which is actually on the ground. So to this, I think we have come to the end of session 6, and we'll just take this moment to appreciate the presenter, and can we clap for him? Yeah, up to this moment, I would ask my colleague if she has a last word to hand over the mic to the chair.
Thank you. Thank you so much. I think for the 3 presentations, there's opportunity for alignment, consolidating our messaging, showcasing in the impact of the work, the amazing work that HCD is doing, opportunities for learning, and just generally resource alignment in terms of even mobilization, looking at the tool, the opportunities there to look at partners, similar partners working in your country, and approaching them if they have opportunity to support similar work. I have a message from the Civil Society Engagement Mechanism for UHC 2030. There are 3 additional opportunities that we can showcase our work at. There are upcoming UHC Day webinars. UHC Day is the 12th of December. And on the UHC 2030, there's a heat map of activities. So for the different teams, if you have something that you can package and share online, you'll see a heat map of all the activities happening in the various countries. So kindly share that kind of feedback with the UHC 2030. There's also a planned virtual parliamentarian and youth rally. And this is planned for the 11th of December. I'm not sure whether that communication went out, but if not, Craig and team could definitely share that information. And then for next year, there's a push for social participation resolution at the next World Health Assembly. And so there's a call for countries to really engage at this point. There's a 0 draft that has been shared with member states for negotiation. So kindly, when you're back home or talking to your teams, kindly just make the case for the prioritization of social participation, because this will then ensure that there's that inclusive governance and the voices of the community, civil society are brought to the fore. So thank you so much. And yes, I'd like to hand over the mic to our session chair.
Thank you, Melissa and Matu, for taking us through this session. And thank you to all our presenters for the good job done. We are now moving to the next session, session number 7, which is on recommitting to the HDC. And let me invite Dr. Ayub to come forward to facilitate this session. This will take us for another hour. So let's welcome Dr. Ayubu as he facilitates this session.
So the video will just be played and we just follow the video.
All right, WHO, it's time to move. So we prepared some exercises for you that are perfect because they are resembling what you're used to every day at your desk. So get up from your chairs and start walking with me. We will go through an entire working day together. So follow me as I do these moves. First thing is this. We're walking to the office, maybe from the car, maybe from all the way from home, from the bus or from the train. Then we get to the office and it's time to sit down. It looks like this. Whoop, oops, no chair. Let's try again. Oops, no chair. Find another place. That's it. Find a chair and try to sit down. Now, let's hand out some orders here so we can get some work done. That looks like this. You do this. You do that. You do this. You do that. And if you are on the receiving end of the orders, it might look like this. Me? No way. Me? No way. Me? No way. Me? No way. Okay, important in the working place is also to give your colleagues praise. So we should be clapping at them. It looks like this. Great job. Great job. Great job. Great job. And the other hand, great job. Great job. Great job. Great job. Okay. Next up is typing some of those dreaded emails. Follow me as we try to type some emails here. Typing, 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 typing. Typing, 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 typing. Typing, 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 typing. Think. Again. Typing, 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 typing. Typing, 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 typing. Typing, 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 and think. Great. I think that's about a working day. Let's walk back from the office to our homes, our families, our loved ones, and be ready for another day tomorrow. Thank you very much for joining, and we are now part of the WHO active community, so welcome to you as well.
We are moving very well towards the end, and I think I'm happy that we are still awake. This session is actually more of recommitting ourselves to what we've been listening, and what do you think about the re-energize HDC? And I think to lead us through all this, I would like to welcome Isabella to lead this session as we move on. Is that okay? You are fine?
I was going to say me, no way, but I realize it's Manya who is giving me instructions, so I have no otherwise.
Yeah, I'm the ministry.
Yeah, that's it, yeah. So thank you very much, Chair, once again. We are going to look at a statement that the Secretariat has proposed and has been shared with all of us on the Google Drive for any inputs, and basically is what our facilitator has said. If you look at the program that we've had for the last 2 days, we said HDC was born 2015-16, the progress that HDC has made, you know, the baby called HDC gave birth to many other key, key constituents. We had the constituents, private sector, partners. We have the HDC working group, and we have seen how they work. We have countries on board right now, about 22, 23 countries on board. We had the numbers that we have. Working with partners, and we had a session 2 where we were discussing how HDC has been working with partners and also for a vision for how to work better with partners. We heard how there was an evaluation, and this just before lunch, we looked at the evaluation recommendations, and the proposals going forward. So the question is, we are the parents of HDC. HDC is the baby, we are the parents. Countries, partners, civil society, I mean, all the stakeholders, we are the baby. We have been asked through the external evaluation to recommit, and perhaps you saw the objectives, you know, scope of work, theory of change. We have heard from countries on how best that they would want HDC to respond to the country needs. So then what is this renewed HDC and how do we recommit to that HDC? So we have general statement. If we could have it projected. On your tables, we have a copy that you could share. Let's have the statement. So we are going to read it. If you have the advantage of having the copy from your table, we can read together, but I'll read for you. Pandula? Okay. So it's basically a statement. So we have been here for 2 days. Out of the many things that we have discussed, out of the many outputs that we have had in the different sessions, this is one of the output. If you can maybe just zoom so that people from behind can see. It's also in our folders. If you could then maybe get there to look at it. So it's a statement on this day. Sorry, we'll change the date. The first draft was done on November 30th. We'll then change to a draft for today. It is titled Committing to the Health Data Collaborative, Better Data for Better Health. If you look at the theory of change and the work plan, our impact is better data for better health. Yeah, so it's tied to the theory of change and everything that we have been doing. So the background, in June 2015, global health leaders and participants in the Summit on Measurement and Accountability for Health endorsed the Health Measurement and Accountability Post-2015 Roadmap and a 5-point call to action. There's a link there. You can Google and see the 5-point call to action that was then. These identified priority actions and targets to strengthen country data and accountability systems for post-2015 Sustainable Development Agenda. Stakeholders interested in collaborating on health data investments formed the Health Data Collaborative, our baby, the HDC. A review of the HDC in January 2020 supported a revised governance structure with stronger links with the SDG GAP Data and Digital Accelerator. For those of us who are here day one, you remember Dr. Mwenya presenting on the SDG GAP. So moving forward, the Health Data Collaborative Annual Stakeholders Hybrid Meeting on 5th and 6th December 2023 in Nairobi builds on, one, an external objective evaluation of the HDC. We discussed this today morning, that provided 5 recommendations, including focus on country impact and the SDG 2030 agenda. The Better Data for Better Health event in May, we've just been taken through that by Carolina just a while ago, focused on investing in country health information systems and health data governance to accelerate progress towards health-related SDGs. The UN 2023 SDG Summit and the 2019 Political Declaration and high-level meeting on universal health coverage, UHC, with renewed focus on SDG targets and communities that are left behind. So after that background, what's our statement as the stakeholders in this room? So we, the HDC stakeholders, all of us here, and the ones who have been also looking at this online, those who are not with us here, the statement is available. We, the HDC stakeholders, recognize the importance of aligning efforts to ensure availability and use of quality data for improved health outcomes. We recognize the role that HDC continues to play in sharing good practices and global tools to strengthen data systems and governance in different countries by leveraging and aligning resources. And resources here is technical resources, financial resources, and political resources at all levels with country-owned plans and priorities for health information system, basically what we've been discussing. Next. We are aware of the renewed interests by stakeholders, or stakeholders indeed, and countries to engage with HDC as it implements the recommendations from the external independent evaluation of 2023. Informed and guided by the HDC principles, again, on your tables, we have a sheet of the principles. When you interact with these, you can click on that link to just see the principles. There are about 8 of them. They are on your table again. Just have a look. So informed and guided by the HDC principles and realizing that countries are at the core of HDC, we stakeholders hereby commit to the following. So now you're in the commitments. Number 1, endorse a renewed HDC by adopting a revised HDC scope, basically the objectives that were taken through in the morning and the aim, an updated theory of change, what we saw in the morning, the HDC work plan 2024-25, a renewed HDC M&E framework, a new HDC governance structure, a renewed HDC country engagement strategy, an updated advocacy and communication strategy. We also commit to supporting the implementation of the HDC work plan 2024-25 with clear focus on country impact through incremental actions and review of progress by the HDC monitoring and evaluation framework. Just maybe to let the people know, once you look at the principles, one of them is we take incremental steps, yeah, towards addressing the country priorities and needs. So number 2, commitment. This is for the countries who are here and the countries who are online and any other country that will be implementing HDC. Countries shall continue to provide stewardship to implement a HDC approach using and strengthening coordination mechanisms that support stakeholder engagement, relevant country guiding frameworks, policies and strategies, operational plans, and M&E plans can help continuously hold stakeholders to account through various in-country accountability mechanisms. So basically, again, countries committing to be at the front, show the stewardship and coordinating all the stakeholders and ensuring that all of us are accountable. Then we have the HDC working group as the other constituent. As the HDC working group shall strengthen their role to produce appropriate global goods and tools that can directly respond to country needs. HDC groups shall provide multi-stakeholder technical support to countries based on the country's specific needs and requests, and provide a platform for countries to learn from each other and share good practices and experiences. Again, a request also that came from the floor. We also have the regional platforms institutes, and here maybe just to clarify, regional platforms also include our regional offices, WHO, UNICEF, UNFPA, and also the other regional institutes that are here, and many others that are not listed. So regional platforms institutes shall play coordination and technical support roles in the respective regions, recognizing the opportunities that this presents for countries and the HDC. Regional platforms institutes commit to work with the HDC working groups to contribute to technical products and support countries to strengthen the health information systems through advocacy, technical support, and capacity building. This will include, but not limited to, 1, data analytics, visualization, and data use and promoting country peer-to-peer learning. and leveraging strengths in research to generate evidence to inform countries and HDC stakeholders. We move to the next quite important stakeholder as well. That's a private sector. Private sector, that's for profit and not for profit. Commit to ethically work with all HDC stakeholders at 3 levels to support innovations, improving the availability, quality, and use of data for decision-making in health for countries in accordance with the national legal frameworks and systems. This includes, but not limited to, harnessing digital solutions, interoperability, data architecture, system administration, data visualization, web technologies that align with country priorities and plans. And you do realize that private sector has an edge on this aspect. In terms of civil society organization, they commit to work with all HDC stakeholders using national, regional, and global structures and HDC working groups to increase the representation of CSOs. As CSOs will promote accountability of all stakeholders to the needs of individual patients and communities, especially those left behind, to improve decisions making with use of disaggregated data. The next is community of partners. Thanks. So community of partners, we stand united to leverage the power of information to influence policies, plans, and budgets to accelerate progress to the SDGs and positive transformations in healthcare systems everywhere by committing to 1, championing country ownership and leadership through aligning and harmonizing our investments around country plans for greater efficiency. Again, this came up from all of us, that we want better alignment by all the partners and the stakeholders that we are working with at the country level. Then responding effectively and efficiently to country-specific requests on strengthening HIS, investment in technology, technical assistance for data collection processes, data analytics, generation of reliable information for decision-making. And there, thank you, Patlita. We have comments, some inputs there. We don't just end at decision-making, but include public health and clinical care. That is appreciated. Then contributing to reducing the country's reporting burden. Then number 4, being held to account at all levels through existing accountability mechanisms. As HDC stakeholders, now all of us, we recognize the power of partnerships and we commit to work with other initiatives with common interests and objectives at all levels, that's global, regional, and country level, based on mutual trust to leverage resources for common priorities to promote better data for better health outcomes. This we agree and do here declare and sign on this day, 6th of December 2023 in Nairobi as follows. Maybe just to clarify that the signing will not be today, but those who are ready, we can, if you are ready. Basically, this was to bring this to the team. You have it also in your folders. We would appreciate, 1, are we ready to commit? I think that's first, the discussion. Number 2, if there are any further inputs that you would want captured, or how you don't want us to capture the statements. Number 3, how we move forward until we get the yellow part finalized. The Secretariat had proposed that we have some sort of public participation, we share out with the stakeholders, because we realize there are many other stakeholders who are not here with us today. And then by end of January, we hope that we'll have gotten inputs from all the stakeholders. And then around Feb, we have the signing by the country, by all stakeholders in general, after receiving your inputs. So back to the chair for further guidance on how we do this. Thank you.
Yeah. Let's thank her for for reading through. I think we need to give some time for us to reflect also if there are any issues. I know some of you are already in need of coffee, but at least we can't leave it with just at that. So are you putting up your hand or you are scratching? Yeah, any other person who is scratching his head, we are noticing, we'll let you speak. Yes.
So it's me first?
Yes,
Okay.
you are first. First.
Okay, sorry. I think probably something need to be defined also. Have some definitions because it's not very clear to me. Private sector is very broad, but it could include commercial companies, you say for profit making. And we have a problem working with Philip Morris, for example, WHO, or tobacco and drugs, this kind of thing. So I think we need to specify what it means by private sector. It could be private sector, which has a role to play in the health sector. Because we all signed this declaration of interest when say you're not supposed to be indulge in traffic of drugs and alcohol or something, or food industry. WHO have all these conditions before you engage with private sector. So I would be very careful in that, and perhaps some definitions of what